Sir, we are live in 3, 2, 1. Sir, we are live now. Please start, sir.
A very good day to all who have joined us here. Myself, Dr. Vinod Kalkoti from Medical Affairs team. On behalf of Vector Division of Intas Pharmaceutical, I welcome all of you to this third edition of Global Update on Diabetes Management. It's indeed my pleasure to be among the presence of galaxy of international experts along with eminent faculty in the field of diabetology from India. Diabetes is one of the largest global health emergencies of the century, ranking among the 10 leading causes of mortality together with cardiovascular disease, respiratory disease, and cancer. By the year 2035, nearly 592 million people are predicted to die of diabetes. Type 2 diabetes, which constitute 90% of all the cases of diabetes earlier, considered to be a disease of the affluent Western countries, has now spread globally and has become a major cause of disability and death, affecting even the younger age group. Diabetes has reached epidemic proportion in many developing economies, especially like China and India. The rapid socio-economic change in conjugation with urbanization and industrialization are the major factor for global increase in diabetes epidemic, with other associated risk factors such as population growth, unhealthy eating habits, and sedentary lifestyle also playing an important role. Diabetes has steadily increased in India and around the world over the last 2 to 3 decades, with India accounting for a sizable portion of the global burden. The estimates in 2019 showed us that about 77 million individuals have diabetes in India, which is expected to rise to over 134 million by the year 2045. Approximately 57% of these individuals remain undiagnosed, which is a quite significant number. With continuous innovations in the management of various metabolic disorders happening on daily basis and in view of new evidences being generated regularly, we are here today to hear from our international experts on the latest update in overall diagnosis, management, and follow-up of diabetic patients. After which we will hear from our Indian counterpart, their take on these topics and how they are going to shape the patient management in days to come. The agenda for today's meeting includes 3 main sessions. Our international faculty will be presenting first, followed by panel discussion with Indian counterparts in each session. Kindly request all the audience to please mute your questions during the panel discussion. To moderate this session, we have with us Dr. S.K. Sharma, Dr. Mala Dharmalingam, and Dr. Vijay Vishwanathan. Dr. S.K. Sharma is currently the consultant endocrinologist at Galaxy Specialty Center, Jaipur. He did his DM in endocrinology from PJ Chandigarh in 1993. Dr. Sharma was the past professor of medicine at Mahatma Gandhi Institute of Medical Sciences. He has over 26 research publications in Index Journal to his credit. Dr. Sharma is the chairperson of Diabetes Welfare Society. He is the regional faculty of Public Health Foundation of India. Dr. Sharma was awarded Rajasthan Health Award Endocrinologist by the Times of India in 2013 and was also awarded by Economic Times as Inspiring Endocrinologist of India. It's indeed my pleasure to welcome him to this session. A warm welcome to you, sir.
Thank you.
Dr. Mala is currently the Director and HOD of the Department of Endocrinology at Bangalore Endocrinology and Diabetic Research Center. Sorry. She is the recipient of multiple awards, including prestigious Dr. B.C. Roy Award, Vocational Excellence Award, and Academic Excellence Award from MS Rama Medical College. Dr. Mala was the past Vice President of Endocrine Society of India in 2011. She has published over 141 research articles in various national and international index journals. Dr. Mala is also the member of CDSEO DCJ Expert Committee and member of Scientific Committee of ICMR. Very warm welcome to you, madam. Our next moderator is Dr. Vijay Vishwanathan. Sorry. He is currently the head and chief diabetologist at MV Hospital and for Diabetes and Professor M. Vishwanathan Diabetes Research Center, Royapuram, Chennai, which is the WHO collaborating center for research, education, and training in diabetes. Dr. Vijay is also the president of the Foot International based in Belgium. He is the National Vice President of Research Society for Study of Diabetes in India from 2019 to 2022. Dr. Vijay has rich clinical experience of 30 years as a diabetologist. He was also recipient of the first Vivian Fonseca Award from the American Diabetic Association for research paper on diabetes and TB in 2013. Dr. Vijay has published over 200 original research articles in diabetic food, diabetic nephropathy, diabetes, and TB, and socioeconomic status in diabetes to his credit. He is the honorary faculty in the Department of Podiatric Medicine in Royal College of Physicians and Surgeons of Glasgow. It's indeed my pleasure to welcome you, sir, to this platform. Now, without any further ado, I'd like to hand over the session to Dr. S.K. Sharma, sir. Over to you. Thank you.
Thank you. Thank you very much, dear friends. Good evening to our speakers, panelists, as well as all the people who have joined in this seminar, in this webinar, I should say. And today we are going to start our first session. And for this, we have Dr. Professor Ildiko Lingwe as a speaker. Dr. Lingwe is a professor of medicine in the Division of Endocrinology, as well as Department of Population and Data Science at UT Southwestern Medical Center. Dr. Lingwe is the medical director of the Office of Clinical Trial Management, overseeing all the clinical trials in UT Southwestern. She is board certified both in obesity medicine as well as endocrinology, diabetes, and metabolism. Dr. Lingwe treats patients at UT clinics and hospital as well as at Parkland Health and hospital system. And Dr. Lingwe is an active member of the American Diabetes Association, where she is serving over the many years in many committees, including organizing committee for the annual scientific session and focus on fellow advisory board as well as WIN ADA advisory board. She has participated in many clinical trials and has a special interest in cardiovascular outcome trials and obesity trials. She authored over 110 publications in major medical journals and authored chapters in several popular diabetic textbooks. So Dr. Lingwe will be telling us about the problem of obesity and how to tackle it. Over to you, ma'am.
Thank you. Thank you for your kind introduction. I will try to share my slides. There you go. Let's see how that goes. All right. So it's my utmost pleasure to talk to you today about a topic that is near and dear to my heart. And hopefully by the end of the presentation, you will see why that is and why I think it's so important for our patients. So I think that weight management should be the primary treatment goal for type 2 diabetes. And I will go through the reasoning for that and how I propose that that should be done. These are some of my disclosures. And you'll very well know that obesity is associated with a slew of complications, over 300 complications if we sit there and count every single one of them. But today we're going to focus in particular on the relationship between obesity and diabetes. And these two conditions are very intricately linked. Not only obesity has a direct effect on causing diabetes by promoting its two core defects, insulin resistance as well as beta cell decompensation, but there are a lot of other associated pathways which cause this relationship to actually be a vicious cycle. So obesity causes sleep disorders like sleep apnea, for example, which further promotes insulin resistance and diabetes. Obesity also limits the ability of our patients to be active, further promoting diabetes, as well as the stigma related with this and the impaired mental health, which definitely also contributes to diabetes. On the other hand, diabetes further promotes obesity through many different mechanisms, including medications that we often use, which lower sugar but promote weight gain. Often our patients get neuropathy, which causes decreased activity, hypoglycemia, which stimulates food intake, and again, the associated mental health that leads for this relationship to turn into a vicious cycle, promoting the advancement of both of these conditions into chronic progressive diseases, which affect our patients' life in significant ways. The only way to stop this vicious cycle is to intervene aggressively and to disrupt this pathway. I want to remind you that this is a continuous relationship over time. So diabetes is part of an underlying continuum of metabolic disorder that patients with obesity develop. Why I'm pointing this out is because depending on where we intervene along this disease continuum, the outcomes and how we measure success is going to be different. For example, in a patient that has not yet developed prediabetes, when we intervene, our outcome might be relevant, like prevention of prediabetes. If we have a patient that already developed prediabetes, then our outcome of interest might be prevention of diabetes. While if somebody already developed diabetes, our outcome might be to prevent complications or to resolve the diabetes. But if they've had it for a long time and maybe already have developed micro and macrovascular complications, then perhaps resolution of diabetes is not an attainable goal, but still improvement in micro and macrovascular complications, improvement in blood sugar and their diabetes overall and quality of life are still very much attainable and are very worthwhile attempting. So I will cover briefly each of these points, and I will primarily focus on the why because I want to convey the message of how important this approach is in management of diabetes and how important weight loss is for treatment of diabetes. So let's see first the experience from the diabetes prevention trial. So when you think of the diabetes continuum, this intervention occurred prior to the development of diabetes in the stage of prediabetes. And this study randomized patients to lifestyle interventions versus usual care versus metformin. In this trial overall, what it was found that every kilogram lost reduced the risk of developing diabetes by 16%. Furthermore, if we talk about these early stages of diabetes, we have a lot of studies on dietary interventions. These are quite effective. As you see here, we have many studies that evaluated strict dietary interventions, either as a single arm or in controlled fashion with standard of care approaches. And what they show unanimously, especially in these populations that have early disease duration, so on average less than 5 years, the more weight loss they have, the more likely to remit diabetes. And generally speaking, for success rates where more than 50% of the cohort would achieve this remission, we will need 2-digit weight loss. So I will come back to that during my presentation, but I wanted to point this fact out. I'm going to highlight 2 of these dietary intervention studies, which I think are quite relevant. This first one is the DIRECT study, which was conducted in England and randomized patients with newly diagnosed diabetes within 2 years of their diagnosis to either receive standard of care or a very intensive dietary intervention with the goal to lose 15 kilograms. The result here is not by the randomized group, but by how much weight loss they were able to achieve during their study. So you see that a very direct dose response effect with more weight loss leading to greater likelihood of diabetes remission. And here in patients who lost more than 10 kilograms, more than half of the patients were able to remit their diabetes, therefore getting off their diabetes medications and having normal glycemia. And in those losing successfully more than 15 kilos, 86% were able to be diabetes-free at 1 year and 70% at 2 years. So very relevant findings. Indeed, these are relatively small studies, but still highlight the fact that the more weight loss our patients lose, the more likely to reverse that timeline of continuum that we discussed earlier and move the diabetes course, the disease course earlier. So reversing the diabetes course. The second study I want to highlight, and I'll mention it several times during my presentation, is the Look Ahead study. This was conducted in the US and randomized patients with diabetes, a little bit longer duration than in the DIRECT study, and randomized to either intensive lifestyle modifications, targeting a weight loss of over 5% along with increase in physical activity versus standard of care. This was a cardiovascular outcome study with the primary goal to look if cardiovascular events were reduced. What I'm showing you on the left is the change in hemoglobin A1C at 1 year based on how much weight loss they lost by that 1 year time mark. And again, you see a very direct relationship with more weight loss leading to greater improvement in hemoglobin A1C. Similar for the fasting plasma glucose, which is shown on the right-hand side. So I hope I convinced you that weight loss leads to improvement in diabetes, and then lifestyle interventions are very successful at that. The problem with lifestyle interventions is that it's rarely sustainable, because these physiological counter-regulatory responses, which after an initial period of success almost always bring the weight back to where it started, and oftentimes even shoot over the initial starting point, which highlight the fact that we need to disrupt this vicious cycle that I mentioned with other interventions that are more durable, chronic, and are able to be sustained long-term. And of course, by these, I mean bariatric surgery or pharmacologic interventions. But I want to highlight that those should never be implemented by themselves. They will always have these lifestyle interventions on the backbone, and only in conjunction with lifestyle interventions are they successful and actually provide an improvement in the overall health of our patients. So let's review a little bit of data about bariatric surgery and type 2 diabetes. We have now several randomized controlled trials that are very relevant for the field. I'm showing you one of these here. It was recently published in Lancet, and this is the 10-year data of a randomized study which assigned patients to either bariatric surgery, either biliopancreatic diversion or Roux-en-Y gastric bypass, or usual medical therapy. And I want to point out that in this particular study, usual medical therapy was actually very intensive. Not only that, but it was able to achieve weight loss of almost 10%, on average 8%, and sustain it over 10 years, which is really an outstanding accomplishment for this group of investigators and their patients. And that very nicely reflects on the graph on the right side, where hemoglobin A1C improved in all patients, more so obviously in patients who lost more weight with a bariatric surgery. And then it was this improvement sustained over time. Now, I know you're looking at these graphs, these hemoglobin A1C graphs, and you see the difference between medical therapy and the surgical groups, which is quite relevant here with a 10-year difference of over 1 point in hemoglobin A1C. But you will say maybe it's not that much, or maybe it's not worth the surgery. But here's what I'm going to point out to you. It is very relevant, because patients who actually got surgery, they were able to accomplish those hemoglobin A1C reductions and maintain that near normal hemoglobin A1C with much fewer medications than patients who were assigned to medical therapy. So here I'm going to point out patients in medical therapy to achieve those very nice A1C reductions. More than 50% were on insulin treatment, while those receiving surgery were 5% at 10 years on insulin and 0 for biliopancreatic diversion. On the other hand, patients on medical therapy, none of them were on 0 therapy, while a quarter of the patients getting gastric bypass were on no therapy whatsoever and still accomplished these near normal blood sugars. And those with biliopancreatic diversion, 60% of them were on no therapy whatsoever. So I hope I've convinced you that weight loss does lead to glycemic control. And the means of inducing the weight loss is really less important how you get that weight loss, as long as it is sustained. Around the amount of weight loss, now, it's important because it determines the magnitude of the glycemic effect. The benefits of weight loss now are seen across the dysglycemic disease continuum. So why I'm pointing this out, because I never want to hear from one of my colleagues is that it's too late to intervene with weight loss. No matter where your patient is in the disease continuum, even if they've had 30 years of diabetes and they already have cardiovascular disease and maybe microvascular complications, even intervening that late into the disease continuum have important beneficial effects and improve glycemia, minimizes further complications. And I'm going to come back and show you that in a little bit. All right, so here's what I want to convince you that the benefits of weight loss are go way beyond just glycemic control. This is a meta-analysis that included the main studies from bariatric surgery. And what it shows that bariatric surgery versus best available medical therapy, which is what we do every day for our patients, has significant benefits on microvascular complications, and not small levels of significance. I mean, look here, retinopathy, it's reduced by 48%. Nephropathy, it's reduced by over 60%. And neuropathy, it's reduced by over 70%. No intervention, no medication in our medical armamentarium is ever going to get our patients to have such great improvements, such reduction in risk for these microvascular complications. This is the Mingrona study that I have shown you earlier that was published last year in Lancet. The randomized study between medical therapy, which I've shown you, it was quite good medical therapy with pretty good improvement in hemoglobin A1C and weight loss in the range of 5 to 8%. And even with these great outcomes in the medical therapy, look at the difference between the surgical procedures, which achieved on average well over 20% weight loss, and the medical therapy. 14 times higher rate of micro and macrovascular complications in the medical therapy compared to surgical therapies. Furthermore, quality of life, which we know our patients care about very much, improved in every single domain with the surgical therapy compared with medical therapy. There are also other benefits to weight loss beyond microvascular complications. Cardiovascular risk factors improve. This is back to the look ahead study, the 1-year data. With each category of weight loss, so with increase in weight loss, we have incremental improvement in cardiovascular risk factors, including systolic and diastolic blood pressure, including triglycerides, including HDL and LDL. But it's not just risk factors. We're seeing significant improvements in heart outcomes, in cardiorenal outcomes. And this is a compilation of studies, and you see at the bottom the numbers, over 2,000 people that were followed in the surgical groups and over 11,000 controls. And all-cause mortality was significantly improved. Heart failure, coronary artery disease, strokes, nephropathy, atrial fibrillation, every single one of these important cardiorenal outcomes were significantly improved with weight loss. Cancer, very important topic, also significantly improved both the obesity-associated cancer cases, so the incidence of cancer improved by 32% with bariatric surgery versus non-surgical control. But also, if you develop cancer, cancer-related mortality is much improved. This happens irrespective of the diabetes, so whether our patients have diabetes or no at the time of the weight loss intervention, the improvements in cancer-associated cases as well as mortality is similar. I want to show you this because it's quite interesting and supports my point. There's a dose-dependent effect between amount of weight loss and improvement in obesity-associated cancer cases, with those patients losing more than 24% of their body weight having the greatest effect. All right, so all-cause mortality. This is sort of the most important endpoint which we're all striving for our patients. And with significant weight loss induced by bariatric surgery, and again, this is a very recent Lancet publication, and look at the numbers. We're talking 65,000 patients with metabolic surgery and 108,000 non-surgical controls, and significant reductions in all-cause mortality over time. Overall, if you look at, we're looking at 1.2 million patient years, and the median life expectancy was improved by over 6 years with bariatric surgery versus controls. And I wanted to everything okay?
Yeah.
Madam, please continue.
All right. So I wanted to point out that this difference in all-cause mortality applies both to patients with diabetes and those without diabetes. So on the left side are patients with diabetes, on the right side, patients without diabetes. And very importantly, those who have diabetes, so more advanced on that disease continuum that I was showing you earlier, their benefit from weight loss was actually greater than patients who have not yet developed diabetes. So the improvement in life expectancy was 9.3 years in those patients who had diabetes at baseline versus 5.1 years in patients who did not have diabetes at baseline. So I've shown you that the benefits of weight loss in patients with diabetes are quite extensive. Glycemic control, microvascular complications, improvements in cardiovascular risk factors, cardiovascular events, cancer mortality, quality of life, and all-cause mortality. And these are just a few of them. There's so many more other outcomes that are improved with weight loss that I don't have time to talk to you about. So what it highlights this is that addressing weight loss represents a holistic approach for the entire person with diabetes. When we're treating a patient with type 2 diabetes, when we're focusing on weight loss, we're not just focusing on treating hyperglycemia and therefore minimizing micro and macrovascular complications, but we're treating the person as a whole and addressing all the comorbidities that lead to these metabolic complications. Therefore, we're having what I call a weight-centric approach and upstream intervention. So let's say how much of this weight loss is needed for improvement in glycemia, for diabetes remission. How much weight loss should I focus on? So this is a study also from the diabetes and bariatric surgery literature. And what it shows is depending on the bracket of weight loss achieved by these patients, what percent of patients achieve diabetes remission. And you see that they need to be losing at least 10 to 15% of their body weight to have a significant reduction in diabetes remission, the significant odds of diabetes remission. And then there's a direct relationship between the more weight loss, the better of this diabetes remission. And this levels off after about 25% weight loss. So many of the comorbidities that I mentioned start improving at 5% weight loss. And then a number of comorbidities, including diabetes remission, including heart failure with preserved ejection fraction, cardiovascular endpoints, start improving at about 10% weight loss. And then the greater the weight loss, the more benefits. And the sweet spot is that 10 to 20% weight loss when all the comorbidities are impacted. And therefore, we recommend to target, ideally, a 15% weight loss. Of course, this is a target that needs to be adjusted based on your patient. And you're very familiar with this graph. It's from the ADA Standards of Care, and it represents how you should select targets for A1C. This is exactly the same concept where we're talking about how much weight loss you should target for your patients. The same variables would make a difference. So if you cross out glycemic and A1C and replace that with weight loss, you have the same parameters that you have to keep in mind when deciding what's the right target for weight loss for your patient. So of course, your question is going to be, how do I achieve these targets? And we've talked about lifestyle interventions, and those are quite effective and they need to be implemented, but they're rarely durable on their own. Therefore, you need additional durable interventions. And one of them is bariatric surgery. It's very effective, it's very durable. And frankly, I think we are all, and I'm guilty of that as well, are underutilizing this very impactful intervention. And we should be recommending it more to our patients and encourage them to explore this option. But of course, many of our patients would prefer a non-invasive approach, therefore pharmacotherapy, which is what will fill this target weight loss of 10 to 20%. And we now start to have many agents in this field, and many more are in the pipelines. Therefore, this topic, it's very relevant at the current time, because while these agents were not available in the past, or those available did not achieve this target weight loss of 10 to 20%, and patients were getting discouraged with the underwhelming effect, the newer agents and the agents in the pipeline currently will be able to deliver this amount of weight loss and hopefully sustain this amount of weight loss in the long term. So let me just point out a few of them. One of them is semaglutide. I understand that this is an agent that will hopefully be coming to India as well. It's already available in the United States. And this is the STEP 2 study, which enrolled patients with diabetes and obesity and followed them for a year and a half. And with a higher dose of 2.4 milligrams of semaglutide, we achieved a 9.6% weight loss on average at the year and a half mark. And for the first time in obesity medicine, we actually were actually successful in a population with diabetes, which we know how hard it is to induce weight loss and maintain weight loss in this population. We were able to achieve more than 15% weight loss in over a quarter of this population. Furthermore, we now have tirzepatide in our armamentarium. This was approved for diabetes in June in the US. Hopefully it's going to come to India as well in the near future, because I am very excited about this agent as well. This is a dual agonist, GLP-1 and GIP, so it harnesses two of the incretin mimetics, and the results are even more impressive. You see on the left are the results of the SURPASS-1 study, and at 40 weeks, so not a year and a half, just 40 weeks, 11% weight loss with the highest dose of tirzepatide, which is 15 milligrams. And if you follow that out to 52 weeks, and that's the SURPASS-3 study on the right-hand side, we have almost 14% weight loss. And we don't have longer than that studies in diabetes, but in obesity, SURMOUNT-1 study was published not that long ago and presented at the ADA this summer. And in patients without diabetes, there was over 22% weight loss at a year and a half. So very impressive results with this agent. And hopefully it will be more widely available for our patients because the results are impressive. So a couple of words about things that, at least in the US, are still in development, but very promising. One of them is this combination of semaglutide, which I've shown you the results of earlier, but in combination with an amylin agonist, cagrilintide. You might remember pramlintide, which was approved many years ago for type 1 diabetes, but it wasn't very popular because of the pragmatic problems, like a very short-acting agent that needed to be injected several times a day. It was effective, but not very practical. This is a once-weekly amylin agonist. And when you combine it with a GLP-1 agonist, the results are quite impressive. At 20 weeks, we saw reductions of 17% in weight, which modeled out to a year and a half. We expect a weight loss in the range of 25-30%, so achieving weight loss comparable to bariatric surgery. There's several other agents in development. I don't have time to present all of them, but the pipeline is quite full, and therefore this field, it's very excited to be in, and we hope that we'll be able to make a difference in our patients' lives with these agents that are coming up. All right, so who should we intervene? And especially for this audience, I want to make a point that obesity does not equal BMI. BMI is really a very poor measure of obesity. It does not reflect even fat quantity adequately, let alone fat quality or distribution. And we have plenty of examples in both directions, when patients with high BMI are perfectly healthy, or patients with low BMI, perfectly normal ranges of BMI, they have diabetes. So we should not be looking at BMI, we should be looking at their overall health. So remember, obesity is fat quantity, location, and function, and not BMI. With that in mind, I want to point out that there are plenty of weight loss studies in patients with diabetes who are non-obese, so with a BMI less than 30. And I'm just showing here a meta-analysis of 21 studies that were conducted, and impressive results in this population with diabetes remission rates up to 90%, despite the fact that they had a normal BMI at the time of the bariatric surgery. One study I'm going to highlight just to show you the impressive results. So patients that were 58 patients with type 2 diabetes who underwent Roux-en-Y gastric bypass, their BMI at baseline was 23, and their improvement was what you would call maybe not that impressive. They went from 23 to 21, but look at their hemoglobin A1C. It went from 9% to to the lower ends of normal glycemia, 4.5%. So please keep in mind, again, obesity is not equal BMI. And even in patients with what we consider normal BMI, they also have obesity, or maybe we call that adiposopathy, but they also benefit from weight loss. So that brings me to this graphic, which tells me that patients with diabetes, the vast majority of them are going to have obesity, or maybe we should call it adiposopathy, not to link it with that BMI. Also, 20-30% of our patients with diabetes have cardiovascular disease. So when we look at diabetes and look at these three categories of patients, we have those who have type 2 diabetes, but they don't have obesity, don't have cardiovascular disease. These are the patients that you all know that have profound insulin secretion defect, and there a glucocentric approach is the right approach. Then you have the patients with cardiovascular disease, in which we have now agents that are proven to reduce the risk of events, and we should have a cardiocentric approach in these patients. In the rest, the vast majority of patients, I would argue, and I hope I convince you today, that we should have a weight-centric approach. So here are these three categories of patients with the adipose-related diabetes, where we should have a weight-centric approach. Their disease is primarily driven by insulin resistance. While in those with cardiovascular disease, their disease is primarily driven by atherosclerosis and inflammation. And in the group with isolated hyperglycemia, it's driven by beta cell dysfunction. Therefore, the targets for these three groups of patients should be different, and we should be targeting weight loss primarily. In the first category, we should target the use of agents with cardioprotective effect in patients with cardiovascular disease, and the normal A1C in the last group. But I want to highlight, this should not be done at the expense of ignoring the other targets that we should have in our patients with diabetes. So we should also have normal glucose, normal blood pressure, normal lipids, and so forth. All of them should be priorities in your patients. So keep in mind that any intervention that we do in our patients have benefits and also drawbacks. But I would argue that in the case of weight loss, the benefits outweigh the drawbacks that we might experience, and we should be mindful of them, manage them appropriately, counsel them appropriately, but it should not deter us from intervening. So to summarize, I hope I told you that treating the disease pathophysiology, treating the underlying problem of diabetes is beneficial because it reverses the course of the disease, minimizes the related complications, and has additional benefits beyond just diabetes. The goal should be 15%, but should be individualized to each of your patients. And you should pick your patients by phenotype and not by BMI. Most patients with diabetes benefit from weight loss and should be applied concurrently with all other applicable disease targets. Effective treatment options do exist, are expanding, so don't give up on our patients. Let's make sure that we emphasize the importance of diabetes, of weight loss in our patients with diabetes. And full disclosure, this presentation is based on a publication that we had in Lancet along with my co-authors there. And we were arguing that obesity management is the present of diabetes treatment. And I'm very proud to say that the ADA and ESAD have heard us and have actually incorporated these suggestions in their most current ADA, ESAD guidelines for diabetes treatment. These were presented at ADA in draft version and will be presented at ESAD next month in the final version and published concurrently in Diabetologia and Diabetes Care. They are advocating 4 pillars of care for patients with diabetes: weight loss, glycemic control, management of cardiovascular risk factors, and management of cardiovascular disease. And they are highlighting the fact that weight loss and glycemic control are 2 primary goals for patients with diabetes. With that, I want to thank you very much for listening, and I am happy to take questions.
Thank you. Thank you, ma'am. Thank you, Dr. Lingwe, for a very beautiful deliberation about the linking of obesity to diabetes and how our patients are benefited if we take care of obesity in the management of our diabetic patients. So with that, I will invite our panel member. We have Dr. R.N. Malhotra, who is our first senior endocrinologist working in Polo Hospital, Hyderabad. He is he has an investigator role in phase 2 and phase 3 studies in many of them. Dr. Malhotra has published many papers in the reputed national as well as international journals, and he has participated and presented paper in various national as well as international conferences too. Our second senior endocrinologist in the panel is Dr. Virendra Dhar. Dr. Dhar is currently consultant endocrinologist at Life Care Medico and Medicare Nursing Home in Jammu, and he has done his studies in Srinagar and also in Bombay in KM Hospital. He has 3 research publications in Index Journal to his credit, and he is recipient of many awards in his endocrine life. Third panelist is none other than Dr. Shaila Sheikh. She is currently consultant endocrinologist at Safi Hospital and Wokhard Hospital, Mumbai. She has worked as a principal investigator in large number of clinical trials. She was awarded the top doctor of Mumbai by TOI Group from 2017 to 2020. And Dr. Sheikh has authored international Hajj and diabetes guidance and IDF DRA guidelines for the patients for who is doing this long fasting. And she has published numerous articles in various reputed international and national journals. And she is a sought after speaker in various forums in India as well as abroad. So with that, I think we should start asking some of the important questions to our panelists. So Dr. Malhotra, may I ask you one important question, that as an endocrinologist, how soon or at what age we need to start thinking of obesity management as a primary prevention of type 2 diabetes in the later part of our life?
If you look at our own population, basically we know that we get diabetes at an earlier age. Our conversion from impaired glucose tolerance to diabetes is much higher, around 18% per year. We're not so metabolic, we're not so high BMI, but we are more metabolically obese. We have more visceral adiposity. It leads to more of insulin defect and the insulin resistance. Now, looking at the strategies to manage weight in our population, the strategy should start from the newborns. If you have got a healthy newborn, they will grow up healthy adults. And for that, we need to focus at the pregnant mothers, manage them well, so they have got a healthy newborn, track their weight from the very start to see that they're not getting weight very rapidly. And once they're adults, to look at the prevention program. We're not talking about medical management or the management by a surgery or a drugs here. We're looking at a lifestyle management. So as soon as the patient comes or the individual comes into contact with the healthcare system, their weight should be tracked and looked at. And if they are overweight or gaining weight rapidly, our intervention should start. And the simplest would be to start a lifestyle management program first, and then think about the other strategy later on.
Thank you, sir. Thank you very much. Dr. Virendra Dhar, since we have so much burden of diabetes as well as obesity, and as Dr. Lingwe correlated that obesity is a very important risk factor for the development of diabetes as well as so many other complications. So is there a need for the national program in obesity management as the problem is growing as an epidemic proportion in our country?
Yes, sir. At the onset, I want to thank Professor Lingwe for an elucidated work and presentation today. It was very informative. And regarding your question, yes, since obesity and diabetes are two epidemics which will make India to surpass China in another 2 decades, so we should have a good, robust obesity control and management program at the national level. And we should always try to start it at our clinics. As Dr. Malhotra has already said, that obesity prevention and tracking should start from newborn, in utero to newborn, then adolescents, adults, and finally, if the patient is diabetic as well. So they are very important. And already we know that at least 5% of body weight should get patient lose to have some effect on maybe metabolic complications, microvascular or cardiovascular, and the patient loses more than 10% at the initial stages, maybe patient will go in diabetes remission. So it's very important for us at an individual level, at collectively at the government level, administrative level, to have obesity control programs and obesity prevention and management programs.
Thank you, sir. Dr. Sheila Sheikh, as Dr. Lingwe highlighted the role of surgery, bariatric surgery particularly, in the management of these obese patients. So there are new drugs now available like semaglutide and tirzepatide. But when you will send your patient for obesity surgery in your day-to-day clinical practice?
Good evening, everybody. Good evening, sir. Sir, one of the most, one statement that ma'am made when she took her lecture was that we are not really using surgery to the extent that we should. I mean, if you look at the guidelines say that it is an accepted option in patients with type 2 diabetes with a BMI more than 35, definitely. In any patient with a BMI between 30 to 35, if this patient is on optimal medical management, including all the medication that we possibly can give. So we are also a country which pays from the pocket. So we always have to keep cost effectiveness also in mind when we are using some of the newer molecules. For example, SEMA, also injectable SEMA is not available in our country. Oral SEMA is available in our country, but again, cost becomes an issue. But at least for 6 months, if the patient has undergone optimal medical management and is still not at goal with a BMI of more than 30, we would definitely, bariatric surgery should be an option we should consider. In our country, in the Asian setup, our BMI would be less than 2.5. So we should keep that in mind at all points of time. That is very important. And a very, very important point that she also made was that we need to now think beyond BMI. Maybe the Edmonton criteria would be something which would give us a little more clinical, a clinical idea of the situation, and then we can make individual decisions. But these are all, again, very, very individual decisions which we would make, sir, for our patients. In any patient where you want to maybe plan a surgery between 30 to 35, then you should make a very, very individual decision.
Thank you, ma'am. Thank you. Dr. Malhotra, we have so much, many drugs which are causing weight loss, but many of them are like GLP-1 receptor agonists, which are very costly. So what is your experience of using a DPP-4 inhibitor like vildagliptin in the management of your obese type 2 diabetic patients?
The DPP-4 inhibitors have basically made our job easier to manage diabetes. They are basically drugs which will not cause hypoglycemia, they not cause weight gain. But primarily using for as a weight loss agent, I'm not very sure how much weight loss they can induce. In association with metformin, you can practically experience the weight loss of 1 to 1.5 kg, but not more than that. So DPP-4 are a good agent for glycemic control, but I do not think they are a great agent for weight loss.
Thank you, sir. Dr. Virendra Dhar, since we have so many drugs evolved in the management of obesity, but many of them were then we stopped using because of significant side effects. But now few of these drugs like liraglutide, semaglutide, and now tirzepatide are now going to be available to our patient till we get those drugs. What is your line of management for these type of patients like metabolic syndrome patients? Please share your clinical experience also.
Yes, sir, that's a very important question from our clinical point of view, because we are clinicians, practicing clinicians. The first step is always lifestyle management. And we give a fair time of around 3 to 6 months for lifestyle measures to have an effect on the patient. That includes exercise and a dietary call and a dietary advice from a proper certified dietitian. And the patient has to be put under surveillance and seen whether the patient is compliant. After 3 to 6 months, if we still think the patient is not coming around after fully checking dietary compliance, exercise, and other quality lifestyle measures, then that is the time to start the patient on weight loss medication. And as you already said in the beginning, that in India, we have only 2 or 3 agents for weight loss. Regarding diabetes therapy, we have SGLT2 inhibitors. Then we have GLP-1A, that is once a week injectable from Lilly. And then from Novo, it is semaglutide, 3, 7, and 10 milligrams, not what is available in the US and West as Lira of 3 milligrams or semi-injection 2.5. We don't have that. Plus, we have in Otherwise, there's an anti-obesity drug that is Orlistat 120 milligrams. But I have used Orlistat 120 milligrams. The only limitation with that drug is you have to give 3 capsules a day. And majority of patients after 2 to 3 weeks simply stop those drugs because they say the number of drugs is too high, number one, and 3 capsules makes it around 150 to 200 rupees per day. And number 3, it causes in some patients a lot of staturia and fecal incontinence. So these are 3 major drawbacks of Orlistat. And we know the amount of weight loss is not to the, it's almost to the tune of 3 to 4 kilos. That's at the max when we use 3 capsules in a patient. Regarding SGLT2 inhibitors, they have proved their mettle as far as diabetes and weight loss management is concerned, but with the caveat that in some patients, not in all the patients, we have to select a patient for SGLT2 inhibitors, especially females, because they are more prone to get genital infection, whether it's upper or lower, with the SGLT2 inhibitors more frequently than what men have when they are put on SGLT2 inhibitors. They have proved their mettle. I have been using SGLT2 inhibitors and I have found on an average, patients lose about 5 to 7 kilos of weight. But if they try to continue this medicine for a number of years, I've seen patients in my clinical practice, even females, after taking SGLT2 inhibitors for 1 year or 2 years, they start getting genital infection. Initially, they never got it, but they start getting it after 1 or 2 years. So it's not dose related only, it's time related also. And number 3, I've lately started using semaglutide of oral semaglutide, what has been got by Novo, but it's too early for me to say how will they affect. But I've used this Trulicity, duraglutide, 0.8 and 1.6 milligrams in around 50, 60 patients. But the only drawback, again, I'm telling is, 1, it's a prick. Again, patients are hesitant to get a prick. And when we tell them that it is for weight loss, they give a sneer. They say, for weight loss, why should I take an injection? And number 2, the question which remains there, which is still unanswered, how much is the weight loss? I am not convinced with the weight loss effect of 1.6 milligram duraglutide I use in patients for 6 months to 1 year. I'm not convinced. Number 2, how many years, how many months you will use this? Will you use this for whole of the life of patient? That's a big question mark, which is still unanswered. So to sum it all, there are only 2 promising agents for weight loss, which have proved and worked in some percentage of patients, because we have to select the patients. One is SGLT2 inhibitors, and next lately, which has come in Indian market, is semaglutide oral.
Tirzepatide. Yeah, thank you. Thank you. Dr. Sheila Sheikh, now we see obesity in our children also, and it is very rapidly increasing. You stand in the front of a school and you find all those chubby kids are there, and the obesity is definitely increasing very high. So what will be your suggestions to the parents to look into or prevent obesity, and how you will be managing it? You are
you're on mute.
Sorry.
Yeah.
So the first thing, when we talk to parents, we have to be very sensitive about what we are going to tell them. I've had issues where, when I've told parents, I've tried to put it very, very subtly and inspire, saying that, look, I think your child's weight is more than what it should be. I've had parents turning back and looking at me and saying, ma'am, my child looks absolutely fine. He's just a healthy child. Why are you actually, because we did this study in schools, in almost 20 schools, and we actually faced this reaction quite often. So the most important thing, I think, is we need to sensitize society on a whole. We also need to, if you honestly ask me, understand ourselves and also transmit the same opinion that obesity is a complex, multifactorial issue. And it is not simply a question of what you eat and what you burn out. Because what, on the contrary, it leads to is a lot of interpersonal stress if you just put it as simply as your child is overweight because he's having so many burgers per day or per week. So I think it requires a lot of sensitivity when you are talking to the parents. Agreed, but having said this, I totally agree that the lifestyle, especially the last 2 years of lockdown, have worsened obesity. Children's lifestyles have gone totally for a toss. Their screen time has increased very, very significantly. Children are nowadays sticking more to their mobile phones and to their laptops rather than having any kind of playtime, which needs a lot more supervision, I feel. We have, sir, now we see 3-year-olds when they come to our clinic, if the parents want them to keep quiet, they're on the mobile phones. So we are moving from a society which is becoming more and more inactive. So I think it's a combined effort. The schools also have to be sensitized regarding the food which is available in canteens, which is invariably very, very high calorie junk food. So, and I think society on the whole also has to go about it in a more empathetic, and I would say in a more sympathetic manner. So it's a combination of everything, inactivity, bad dietary habits, a lot of high calorie junk food which is being consumed by children at this point of time, and of course the genetic contribution along with the genophenotype which we Asians, Indian Asians typically have. So I think it's a combination of everything, and we have to tackle things at every point. We cannot expect just a single individual to be able to do it. It's first a family, then a society, then a country, which has to totally together handle it.
Thank you, ma'am. Thank you for giving your very practical suggestions. So I think we have taken care of this first session of today's evening, and we are thankful to Dr. Lingve, Dr. Malhotra, Dr. Dhar, and Dr. Shaila Sheikh for their very important input. And I hand over the things to Dr. Vinod.
Thank you, Dr. S.K. Sharma. Thank you. Now let's quickly, I'd welcome Dr. Mala Dharmalingam over to the proceedings. So let me share the screen. Yes, ma'am, over to you, ma'am.
Thank you, Dr. Vinod, for the invitation and a wonderful session. We have finished on obesity, and we are towards another wonderful session on NAFLD, on non-alcoholic fatty liver disease. Equally important, and maybe one of the forerunners in our country. So to deliver to us about NAFLD and its problems, we have none other than Professor Arun Sanyal, who is a graduate from Maulana Azad Medical College in Delhi, and he did his MD at AIIMS. He's currently director at Stravit Sanyal Institute of Liver Disease and Metabolic Health at Virginia Commonwealth University. He's continuously funded physician scientist from NIH from 1995, and he's chair of NIH-NASH Clinical Research Network. He is also chair at FNIH Consortium for Biomarkers in Liver Disease and Fibrosis, and a chair at Hepatobiliary Studies section of NIH. He is president of American Association of Study of Liver Disease from 2010. He's also founding member of the American Board of Internal Medicine for Transplant Hepatology. He has more than 450 papers. His H index is 131. He's published in all the leading journals, and he's led to multiple global phase 2 and phase 3 programs in NASH. And he's a Distinguished Mentors Award of AGA and AASLD from American Liver Foundation from the state of Virginia. And he's founded the Liver Forum, which brings FDA together with EMA to work on regulatory developments of therapeutics for liver disease. He's ranked in Stanford University is top 0.1% of all medical scientists in terms of impact. So we welcome Professor Sanyal to take us through his insights on NAFLD.
Thank you. Let me share my screen. I need to share my screen.
Yes, sir. You can share it, sir.
Okay. Okay. Can you see my screen now?
Yes,
yes.
it is visible, but you have to make it
Yeah.
screenshot.
There you go. How about now?
Yes, perfect. Please go ahead.
Perfect. Okay. Thank you so much for this invitation. And I think the previous lecture on obesity was a perfect setup for me. And as you will see that even though we did not share our slides, we will land on many common themes over here. So the topic that I am going to talk about is the role of non-alcoholic fatty liver disease in diabetes. Here are my disclosures. So all of you recognize that your patient with diabetes commonly has many risk factors, including cardiovascular disease, peripheral vascular disease, diastolic dysfunction, chronic kidney disease. And what I would like to talk to you today about is the involvement of the liver in this cluster of end organ diseases, which are all connected biologically through this process of metabolically driven inflammation and fibrosis, and at the root cause of which is diet-induced obesity. And all of this is leading to this cluster of metabolically driven end organ diseases, which are now a leading cause of morbidity and mortality throughout the world, which we originally recognized primarily in the context of cardiovascular disease and the metabolic syndrome. But as there's a much larger expanded understanding of this cluster at this point in time. So from a liver perspective, the consequence of having underlying metabolic stress from caloric excess, and I'm using this term rather loosely, is the development of excess fat in the liver. Now, when you have excess fat in the liver, it can present in two different phenotypes. One where you only get fat and not much else. There is not much injury, there's not much fibrosis, there is no inflammation, and that's called a non-alcoholic fatty liver. Non-alcoholic, because a very similar histological picture can be seen in people who consume a lot of alcohol. There is a second lesion, which is a more ominous lesion, and this is called steatohepatitis. Steatohepatitis is not simply fat and inflammation, but actually involves this very specific lesion called hepatocellular ballooning, which is shown in the middle panel here with an arrow. And so when you have steatosis, which injures the cells show that injury in the form of ballooning. This then can lead to progressive injury, cell death, triggering inflammation, which in turn triggers a fibrogenic response leading to cirrhosis. So non-alcoholic steatohepatitis is a much more aggressive lesion and is more likely to lead to consequences. Together, non-alcoholic fatty liver and non-alcoholic steatohepatitis are considered under the umbrella term of non-alcoholic fatty liver disease. There are a couple of key concepts that one must think about in terms of this condition. Now, imagine the liver, which starts as being normal, develops fatty liver and progresses all the way to cirrhosis. The analogy I would like to draw to you is like a car that, for example, you're driving in a car from point A to point B. So from disease onset to cirrhosis, which is the ultimate destination for the disease. Disease activity refers to all of the biological processes that is driving the liver disease forward from its original development to cirrhosis, whereas disease stage tells how far the disease has actually progressed. So if you're driving a car, disease activity would be like the RPMs on your dashboard, which shows how hard the engine is working. And disease stage is the odometer, which tells you how many miles you have traveled. Under the microscope, the presence of steatohepatitis as opposed to fatty liver indicates activity. There are also specific activity scores that are based on the histologic severity of steatosis, ballooning, and inflammation, whereas stage is fibrosis. And so steatosis represents the root cause of metabolic perturbation and the delivery of excess fat and sugar to the liver, whereas ballooning is the marker of injury, and of course, inflammation is the result of injury. Now, cirrhosis is when you get liver-related outcomes. So fibrosis is a critical piece of this story because it tells us how close you are to cirrhosis and thus your proximity to clinical outcomes. NAFLD is a global problem, and you can see around the world that almost a third of the adult population has excess fat in their liver. And about a quarter of these people actually have steatohepatitis. And now if you take this world map and replace it with obesity, diabetes, cardiovascular disease, CKD, it all starts looking remarkably similar because they're all connected at the root cause through this global pandemic or that is linked to obesity. Now this is shown in this table over here because if you look at the general population and then look at individuals with fatty liver and then NASH, there is a progressive overrepresentation of obesity, type 2 diabetes, hypertension, hypertriglyceridemia, and the metabolic syndrome. So those who have NASH, 2/3, almost 70% of them will also have will have full-blown metabolic syndrome. Conversely, if you go into your diabetes clinics, and particularly in diabetics who are obese, you will see that the prevalence of fatty liver disease is over 80%. So your pretest probability of having excess fat in the liver is remarkably high. And in this population, in those who have type 2 diabetes, because of that enrichment that I previously showed you, about 56% actually have steatohepatitis. So whereas in a general population, that number is closer to 20 to 25%, in patients with type 2 diabetes, the likelihood of having the more aggressive lesion, steatohepatitis, is significantly higher. So the next point I would like to make is the central role of the liver and the development of fatty liver disease in the context of metabolic ill health. So some years ago, now the Mayo Clinic group published a survival paper based on Olmsted County data, which is their local region, and showed that compared to the general population, those who had excess fat in the liver had a decreased in all-cause mortality. So there was, compared to general population with 87%, the fatty liver disease population was 77%. And the excess mortality was accounted for by a number of cancers, by excess cardiovascular disease over and above background, and then an excess of liver disease. Now, there was always been debate about whether the increased cardiovascular outcomes in patients with fatty liver disease is linked to the liver disease or whether this is just reflective of the background obesity and the enrichment of type 2 diabetes and other risk factors for cardiovascular disease in this population. So this was addressed in this study from Harvard, where they looked at 10,000 patients, and then they looked at those who had imaging done. About 3,750 of them actually had liver imaging done, and they looked at those with steatosis and without. And then after correction for a number of comorbid risk factors for cardiovascular disease, they still found a highly significant hazard ratio of 1.72 for increased cardiovascular outcomes in patients with steatosis compared to those who did not have steatosis. Now, some years ago, we further showed using precision cut liver biopsies that once you expose them to labeled precursors, that the actual formation of cholesterol compared to normal individuals is significantly increased in fatty liver, increases further in NASH, but very interestingly, declines as you get cirrhosis. And also as you progress to cirrhosis, actually the fat tends to disappear from the liver as well. We see a similar thing for triglyceride. And then if you look at the apolipoprotein B levels, you can see a significant step up in patients with NASH. And all of these are controlled by hyperinsulinemia. So whereas in insulin resistance, you have resistance to the functions of insulin in peripheral organs, the liver tends to retain its sensitivity to insulin for a longer period of time. And you get a much more robust lipogenic response when you are exposed to appropriate precursors in the liver till you get to cirrhosis when the insulin resistance catches up and you actually get that increase in de novo lipogenesis, and your ApoB, all of those things start going back down. And this is shown over here that in terms of cardiovascular disease, despite accumulation of free cholesterol, which is very cytotoxic in the liver, you see a substantial increase in HMG-CoA reductase expression. This, of course, is the rate-limiting step for cholesterol synthesis. And as you go from fatty liver to NASH and compared to lean control and then obese controls, you can see that patients with fatty liver disease have significantly increased HMG-CoA. And while at the mRNA level, the SREBP2 did not look different, actually, when you look at the nuclear extracts, which is activated SREBP2, which is the transcriptional factor that controls cholesterol synthesis, it is increased. And very interestingly, at least at a transcriptional level, the LDL receptor seems to be decreased over here. We further show that the HMG-CoA reductase expression level was linked to LDL cholesterol. And we looked at validated measures of cholesterol synthesis, which is desmosterol to total cholesterol in this population, and can show a step up over here. Whereas the beta cytosterol, which is reflective of dietary absorbed cholesterol, cholesterol that's derived from diet, that really did not look that different over here. So what does this mean for in terms of regular cardiovascular risk? Under normal circumstances, when the liver makes a small amount of triglyceride, the VLDL particles that are produced are relatively small, leading to LDL particles of a certain size. Now, when you get fatty liver disease and you have this increase in triglycerides that I showed you, this triglyceride is put out by the liver in terms of much larger VLDL particles. Now, normally VLDL is acted on by lipoprotein lipase to get rid of the triglyceride to generate an IDL and then LDL particle, which is primarily cholesterol. But if this particle is very big, the lipoprotein lipase cannot get to all the triglyceride, and you basically generate triglyceride-rich intermediate density lipoproteins, which are susceptible to hepatic lipases. So for any given level of cholesterol, you actually have many more particles, and these are small and they are dense, and these are small, dense LDL particles, which are more atherogenic. They're able to penetrate the endothelium more easily, produce a more inflammatory reaction. So we're beginning to connect the dots. Now, this is another data from another study that we published last year in the New England Journal, where we followed almost 2,000 patients for up to 10 years. This is the first large prospective study with prospectively adjudicated outcomes in fatty liver disease. And what I would like to draw your attention to is not only the step up in mortality as you progress from early stages to stage 4, which is cirrhosis, in terms of the incidence of mortality, but look at the incidence. So previously I showed you prevalence. Now I'm showing you incidence, that as you go from early stage to advanced stages, there is a progressive step up in the incidence of hypertension, a decline in GFR, and the development of type 2 diabetes. So what this is telling you is that there is a collinear process going on. As the liver disease progresses and the liver gets stiffer, the arteries get stiffer, the kidneys start getting stiffer, and the GFR starts declining, the pancreas starts blowing out, and you start exhausting your beta cells. So there is a collinearity of all of this process, all linked to underlying obesity and metabolic inflammation. And here are the mortality data, which shows clearly a progressive increase with, of course, a big step up when you get to cirrhosis in terms of all-cause mortality. Now, this is what we are looking at currently. These are projections from 2015 to 2030, where at least in the US, we have almost 80-something million people with fatty liver disease, most of whom, luckily, have no fibrosis, so they are at low risk. But we have almost 600,000 people with cirrhosis currently in the US. At the current rate of increase, we think this is going to increase 2 to 3-fold. And the number of people needing liver transplants, and you remember, transplants are limited by the number of organs available. And this has already, about half our transplants are from NASH. And this is a leading indication for liver transplant in women already. and the leading indication for hepatocellular carcinoma requiring transplant in the US. And then this was likely to almost double. But we can't transplant our way out of this because there are many thousand patients more who have end-stage liver disease than there will be organs available. So what does this mean for our clinical practice? So let me first then now talk about the evaluation of NAFLD in a patient with type 2 diabetes. So our goal, first thing I want to point out is that in our patient, as a hepatologist, I'm thinking about the liver. If you're a diabetologist, historically, you've been thinking about blood sugars, which, by the way, are more linked to retinopathy and microangiopathy than macrovascular outcomes. But now everybody's recognizing the role of macrovascular outcomes. If you're a cardiologist, you look at the cardiovascular stuff and so on and so forth. But these are all competing threads. All of this action is going on in the same patient. So from a patient-centric point of view, these are competing threats to life. And one of the unmet needs in the field is to develop better algorithms. So in an individual patient at an individual point of time, we should be able to understand in a more holistically, what are the different competing threats to life? And we already are attacking many of these individually, and many of these are part of your routine practice, from checking the blood pressure, lipid profile, C-reactive protein, EKG, fasting glucose. Some of you may be also checking fasting insulin in people who haven't completely blown out their pancreas, EGFR, etc. So now the question is, having showed you what the burden of fatty liver disease is, and not only the ripple effect of fatty liver disease on cardiovascular and other end organs, how do we assess this? So I want to break this down into three simple questions. Is fatty liver disease present? Does it require intervention? And if so, what intervention? So from my perspective, if you're a diabetes doctor, and I guess today we're talking about diabetes primarily, and particularly if you're obese, if you did no test at all and you called everybody as fatty liver disease, you'd be right 4 times out of 5. So the pre-test probability is so high. You don't need 10,000 tests to really, you just assume for a moment everybody has a little excess fat in the liver in your diabetic population, particularly if they're a little overweight or obese, and overweight, obese by Indian standards. A much more interesting question is, do you have enough liver disease that I need to worry about, right? Because that's the one then I'll need to do something about. So let's look at that. So this is a study with 2,500 patients with fatty liver disease that we followed prospectively. And we divided them into 3 categories. And we used a test called FIB4. Now, if you all have a cell phone, you can Google it as we're talking and put in FIB4. And it is a calculator, risk calculator for fibrosis. I already showed you that fibrosis was linked to outcomes. So we developed FIB4 about 15, 16 years ago. Actually, it was a different study. One of my people, it was developed in my unit to assess fibrosis in people with HIV liver disease, but now has been validated in many other disease states. So you have to input the age, AST, ALT, and the platelet count, okay? And it gives you a number. And you can do it on your cell phone. So FIB4 under 1.3, greater than 2.6, and these are cut off because you have very little scar tissue under 1.3. Above 2.6, you have advanced fibrosis close to cirrhosis. And in between, you have some scarring, but it's not, at the close to cirrhosis. So when you do it this way, you can see again a very nice layering of mortality going from 0.07 per 100 person years, 4-fold to 0.42, and then a log-fold increase almost to 3 when you go to advanced disease. Liver events also exponential increase in this advanced category, stepwise increase in MACE, and also an increase in risk of hepatocellular carcinoma. The overall OROC for mortality, 0.84. So this tells you if you just do something very simple, all you need is a hepatic panel and a blood count with platelets. You can compute the FIB4, and this gives us sort of a basic guidance for how we should look at this. Now, remember, many of your patients may have abnormal ALTs, and abnormal ALT does not always immediately equal fatty liver disease. You still have to ask about alcohol use. And my experience from my visits to India now is that alcohol use is rampant, particularly in certain populations. And so you have to ask about alcohol. And there's still a lot of viral hepatitis in India, and you have to ask about viral hepatitis in inappropriate populations. Check for hepatitis B and C at least, because they're very specific therapies. Now, if it is less than 1.3, as I've shown you, the risk of a liver outcome is minuscule. You do not need, you just need to follow. You have to understand the competing threats here are obesity, cardiovascular, etc. And that's what you need to focus on. Now, once it's above 1.3, particularly if it's more than 2.6, that means, especially those who are above 2.6, that is the population that probably has bridging fibrosis or getting close to cirrhosis, or even has cirrhosis, but the patient is still asymptomatic. Unfortunately, many patients with liver disease will not manifest until they actually develop a complication of cirrhosis. And that's suboptimal. So if you see this, that's the patient that goes to a GI hepatology. And in the middle, we can start thinking about additional therapies where you treat the root cause, which also may have benefit for the underlying liver disease. So for those who have advanced fibrosis, another test that is now being developed, and this is coming into India, and this is called the Extended Liver Fibrosis Test, or the ELF test. And this is the only approved test, non-invasive test by the FDA for assessment of risk in NASH. And you can see over here if the score is a blood test, and if the score is above 9.8, you have a step up in progression to cirrhosis, and then for above 11.3, further step up. And in those who already have cirrhosis, above 11.3 is associated with a significant amount increase in clinical outcomes. Another test that is often used is called FibroScan, where you put an ultrasound probe which fires a single burst of sound through the liver, and what you measure from the shear wave is the elasticity of the liver or the stiffness of the liver. Now, the harder the liver, the more scarred it is, the harder it becomes, the faster sound travels through it. And from that, you get a liver stiffness measure as shown over here. And that generates the shear wave. And if you look at the results from this shear wave, once again, you can see a nice prediction model of mortality based on FibroScan, both for overall survival, and this, of course, shows survival free of liver-related complications. Now, you can measure liver stiffness with MRI through something called 2D MR elastography. And this also shows that it is linked to the likelihood that somebody will progress to cirrhosis, and if you have cirrhosis, that you will progress to clinical outcomes. There's another tool that is used, which is called the corrected T1, which is a measure of tissue water, which is increased in inflammation and fibrosis. This is increasingly being used in cardiovascular medicine and in hepatology also. We have shown that if the corrected T1 is over 825, that those patients have a much higher risk of clinical outcome. So we have a number of tools now to risk stratify our population. So if you're over 2.6 over here and your ELF is over 11.3, this is a patient who is close to decompensating. They definitely need to be followed in hepatology. Between 9.8 and 11.3, they have advanced disease at high risk. They definitely need therapy, probably best treated still in hepatology. Now, there's a lot of work to develop further refinement of the risk strata for people who fall in the middle. But given that there is a clear step up of risk from 1.3 to 2.6, you may also decide to treat. And so treatment over here could be based on things that are treating the underlying root cause, the obesity, metabolic syndrome, etc., which you should be treating in any case. So we've touched on weight loss in our previous conversations. We have listed sort of our current sort of high-level therapies that are being used to improve the outcomes of individual end organs. Weight loss also benefits NASH and improves both steatohepatitis as well as fibrosis. But in terms of drug therapy, GLPs are now beginning to emerge as an anchor therapy. So this is a study we published in the New England Journal a couple of years ago. And what you see over here in this phase 2 study is that 0.4 milligram daily produced almost 60% resolution of steatohepatitis. compared to 17.2% in placebo. This was, however, not clearly reflected in a change in fibrosis stages, which was a little disappointing. Now, if you take a deeper dive and look, remember that activity drives the stage. I showed you that earlier. And steatohepatitis is the activity. So if you shut off the activity, the fibrosis first will slow down, then it will stabilize, and then the natural fibrosis resolution biology will kick in and start resolving the fibrosis. So you expect the first thing to happen would be a reduction in fibrosis. So if you look at the pink wedge over here in placebo, the number of people who had less progression is 18.8% in placebo. Now, when you go to semaglutide, you start from 0.1 and go to 0.4. That number drops to 10, then 7.7, and then 4.9. So there's a dose-dependent decrease in the progression of fibrosis, which suggests to us that the drug actually is slowing down the disease. This is currently in phase 3 through a trial called ESSENCE, which is a global trial that we're working on, and we hope we will have the results for you in a couple of years. SGLT2s are a little bit behind in development compared to GLP-1s. The published results are shown over here. We really do not have high quality histology data. Most of the data is based on MR-based assessment of fat reduction in the liver. PPAR gammas are the classic insulin sensitizers and have been used. And so what I show over here are the data from the PIVENS trial, which we published in the New England Journal 10 plus years ago, and where both vitamin E and pioglitazone were effective. The second set of pioglitazone data are for Ken Cusi's single center study at University of Florida, which basically replicates and shows that it not only improves steatohepatitis, but also has a modest improvement in terms of fibrosis. The point, of course, here is that these studies were not powered for the effect size that is seen with fibrosis. What is very exciting for us in the liver world is a drug called lanifibranor, which is a pan-PPAR agonist. And this is the only drug that in phase 2 significantly improved NASH resolution without worsening fibrosis, improved fibrosis without having any adverse effects on the NASH, and the conjoint endpoint of NASH resolution and fibrosis improvement. This is also in global phase 3 at this time. Talk would not be complete without bariatrics, and bariatrics clearly not only improves cardiovascular outcomes, but improves steatohepatitis and improves fibrosis. But it's not always predictable. 12% of these patients can get worsening fibrosis. The overall scientific quality of the bariatric literature is not very high from a liver perspective. And very importantly, there is now growing concern about an increased risk of suicide and accelerated alcohol abuse in this population. And those who have cirrhosis, you can tip them into liver failure. So this is not for everybody. It is a solution. It is not the solution. So you have to be careful about this. So if you look at the other players that are in play, we've talked about the thiazolidinediones. Saroglitazar is available in India. It's a PPAR alpha gamma, which is approved for diabetic dyslipidemia, has a nice anti-dyslipidemic effect. It is also approved in India for NASH, but I think the quality of the histological data, I think we need more rigorous data. Plus, to my knowledge, the Indian data has not yet been published. And then there's a lot of work going on with bile acids. I did not touch on it because of limitation of time. And it also can increase LDL cholesterol. These are ongoing phase 3 studies. Unfortunately, FGF21, which seemed early on to be a very effective pathway, has not really panned out yet as a major player in the NASH space. Thyroxine beta receptors have a very good, which are relatively liver specific, have a very good effect on the dyslipidemia. They are very good at defatting and improving NASH. The fibrosis benefit remains to be shown in a convincing manner, but this phase 3 trial should be reading out later this year. And we've talked about GLP-1s. And then there's another class called fatty acid bile acid conjugates, which are very well tolerated, which are also early in phase 3 development. So this is sort of the overall landscape, many of which, of course, overlap with the drugs that you use in your diabetes practice. So I'll finish by talking about where I think the future of NASH therapy is going to go, where we start with weight loss regimens, which is a root cause therapy, and follow, and you use statins as indicated. And particularly if your small dense LDL is increased, you should, and your triglycerides are increased, may consider adding fibrates to improve the small dense LDL in this population. Increasing use of SGLT2 and GLP anchored therapies. And then I didn't really talk about this, but insulin can further increase hepatic steatosis. So you really have to and weight gain. And particularly for your patients who have advanced fibrosis, this can be really bad for their liver. And so I would try and minimize the use of insulin to the extent possible, and then reassess the patient. And those who still have significant disease, for them, we will in the future need liver-targeted therapy with the goal of reducing mortality, healthcare cost, function, and improving quality of life. And this is similarly reflected. Basically, this is the most recent American diabetes guidance for the management of diabetes in patients with fatty liver disease. The threshold, you once again see the FIB4 cutoff of 1.3 and 2.6, and then intermediate ranges in the middle, and so on and so forth over here. So with that, I will stop, and I would like to point out that, long ago, our ancestors recognized that superior doctors prevent disease, mediocre doctors treat it before it is evident, and only inferior doctors treat the full-blown disease. And we have a moral imperative to take this on and really develop national preventive strategies rather than put a finger in the dike to stop this problem. Thank you.
Thank you, Professor Sanyal, for elegantly taking us through the prevalence of the disease, the importance of looking at it. Like we always thought that, okay, maybe they all come from the food, and you have shown us that it is not the food that is important. And then, of course, you've talked to us about the management. So now I will invite the panel from India, who is go along with Professor Sanyal. And we have our first panelist, Dr. Anish Bahl. Dr. Anish is a consultant endocrinologist at Apollo VGS Hospital and Wellness Super Specialty Center at Mysore. He is his special area of interest is type 1 diabetes, metabolic bone disease, and autoimmune thyroid disorders. And he has published many papers in national and international journals. And the second panelist for today is Dr. Sanjeev Phatak. He is a founder of Vijayaratna Diabetes Diagnosis Center and Treatment Center in Ahmedabad. He's also associated as an investigator and consultant with DHL Research Center in Ahmedabad. He's the first diabetologist in India to practice with insulin pump therapy, and he has fellowship in advanced diabetology and islet transplant training from UK, Oxford. And the third panelist for today is Dr. Dakshita, and she is a preventive diabetologist and director at Conquer Diabetes Center, Mumbai. She's founder of Om Diabetes Club, which is a support group of 15,000 diabetes patients. And she has international publications in preventive podiatry in IDF, ATTD, and a faculty speaker for the national conference. Dr. Dakshita was awarded for state-of-the-art diabetic foot clinic in 2018. I welcome all the panelists for today. And the first question, let me ask Dr. Dakshita, how common, we have heard Dr. Sanyal talk about it, but how common is NAFLD in your own practice?
Okay, hello everyone, and sir, Dr. Arun Sanyal sir, I want to thank you for always guiding me. You are my mentor indirectly. So when I'm talking about NAFLD, few years back, for me NAFLD was fatty liver disease on sonography, or either any patient coming to me with history of hemoptysis or ascites or liver failure when nothing can be done. So I wasn't doing anything, whatever is happening in between. Then I started attending sir's lecture in ATTD, NASH meetings, and ADA. And then I got hold of this investigation called FIB-4 score. We started doing some work on FIB-4 score. And just to mention now, in last 2 years, we have diagnosed so many asymptomatic patients who don't have, maybe their liver panel is absolutely normal, their HbA1c is normal, but the percentage of patient having FIB score more than 1.4 or to the extent more than 2.0 is very high. Last year, we presented this paper in Paris NASH meeting. So around 438 women were evaluated for FIB score. And I would like to share the data that less than 1.3 were 368. But between 1.3 to 2.6, asymptomatic patients having FIB score between 1.4 to 2.6 were 58. Between 2.6 to 3.2 were 5, and patients who were absolutely asymptomatic, but the FIB score above 3.2, the number of patients were 7. Then we realized what is the importance of doing FIB score, and these patients were started on lifestyle modification and everything. But after using FIB score, probably we came to know what is the burden of NAFLD or patients who are pre-cirrhotic in our Indian setup. And
So
then we did fiber. Yeah.
Yeah, so thanks, Dakshita. So you agree with Professor Sanyal that 4 out of 5 will have a fatty liver or an NAFLD in our country using the FIB score. And I also understand that that's your screening method to look at and screen for NAFLD. Thank you very much for that. Having known that the prevalence is so high, let me go to Dr. Anish. And Dr. Anish, what is your thoughts on lifestyle in prevention of NAFLD?
I think Dr. Arun Sanyal rightly said, lifestyle is probably the most important aspect of management of these patients, because with weight loss, you can expect a significant improvement in liver histology. Even a 5% reduction in weight can make a significant difference. And studies have shown that probably a 5% reduction can reduce hepatic steatosis. If you can achieve up to 10% of weight loss, you can also have some degree of fibrosis regression or maybe stability of fibrosis. So weight loss, whatever method you use, you can use just lifestyle, you can use pharmacotherapy, and as Sir showed that data with bariatric surgery, where you can see a very good amount of improvement in hepatic, in NAFLD outcomes. So I think lifestyle is probably the mainstay of treatment in these patients.
So thank you, Dr. Anish. And yes, all the lifestyle modalities, but he also said caution bariatric surgery.
Yes.
Yeah. So thank you for that. And Dr. Pathak, NAFLD is in the national program in India. How do you think it should be implemented, and what can we do to increase the awareness and implementation of this program? You're muted, I think.
Yes, thank you, Madam Dr. Mala Dharmikam. And thank you, Dr. Arun, for wonderful talk. And as Dr. Dakshita rightly told that we have been attending his seminars in most of the meetings. And NAFLD spectrum has totally changed the way we used to perceive NAFLD in the past. But in last 5-10 years, with calculation of FIB-4, I think we are seeing more and more, we are rather detecting more and more people with NAFLD. And I think we must thank our government also, Dr. Harshvardhan and the team, for bringing this in the national program. Because now the national program includes educating the people about NAFLD right from the school age, I think, and preventing NAFLD through lifestyle measures, dietary changes, some dietary changes which we were also not aware, incorporating coconut oil or safflower oil and some fruits. Some fruits actually can worsen the NAFLD that we were not aware. So I think the national program will help a lot in preventing this disease, because we are having an epidemic or rather pandemic of obesity in our country.
So thank you, Dr. Pathak, and it's really true. Unless it is taken up by the administrators in a big way, then we can see a positive change. And like Dr. Sheila said in the previous lecture, one person or a group cannot make a difference as a governance can. So we go back to Dr. Anish. And Anish, what is your preferred anti-diabetic agents in type 2 diabetes and NAFLD?
I think the first choice would definitely be GLP-1 receptor analogs. And the data is maximum for semaglutide and to some extent with liraglutide also. But in India, injectable semaglutide is not available as of now. So most of us probably use liraglutide, and that has shown some amount of positive data. The other agent which has shown to be very beneficial is pioglitazone, in spite of the fact that pioglitazone can cause weight gain, but as far as liver outcomes are concerned in NFLD, it's really been very good. In fact, meta-analysis have shown that there is resolution of NASH and also to some extent fibrosis also with pioglitazone. SGLT inhibitors, again, Dr. Arun rightly showed that there is evidence that because of weight reduction, you can have some degree of improvement in hepatic steatosis. But most of these studies which are done with SGLT inhibitors are done using imaging modalities. There are very few studies which are available where they've looked at histology per se to see whether there is a reduction in steatosis or fibrosis with SGLT. So as of now, I think the best option would be a GLP-1 receptor analog followed by pioglitazone and then SGLT inhibitors.
So thank you, Dr. Anish. And we'll go back to Dr. Pathak. And what is your experience on statins? And we've known that cholesterol and triglycerides are a major problem. So what is your take on statins and other medications for NAFLD, in NAFLD and diabetes, of course?
So there's a paradigm shift. Previously, our gastroenterologist colleagues used to say that don't give statins with liver disease. And now the things have totally changed. We know that people with NAFLD are at more risk of atherosclerosis and cardiovascular disease. So statins definitely are indicated regardless of the SGPT levels. But of course, if the SGPT rises 5 times after starting a statin, one has to be careful. Otherwise, statins are indicated as a atherosclerosis or other cardiovascular disease prevention agents. One more comment I would like to make here is that the SGLT2 inhibitors, though it may not have data, but these NAFLD patients are also at higher risk of heart failure also, which was recently published in Gut, maybe last week or so. So I think SGLT2, pioglitazone also have a very good place together for our NAFLD patients. Of course, GLP-1, but GLP-1 many of our patients cannot afford.
So I think we have a little bit of clarity in our own country, what we should be doing. Of course, GLP-1 is quite unaffordable in our country right now. But yes, the other modalities of therapies that you have indicated. So to conclude—
If I may, can I add something over here?
Sure, please.
So one thing, because you remember I showed you there's a collinearity that the patients with stage 3, stage 4 are more likely to have hypertension, CKD, all of these other things. So as the liver becomes more stiff, the heart becomes more stiff as well. So particularly those who have a FIB4 over 2.6, it may be it is at least my practice to also check a BNP and get an echo just to look for diastolic dysfunction. And if they have any evidence of significant diastolic dysfunction, then I use the SGLT2 because I'm treating the diastolic dysfunction. If there is any decline in eGFR, I'm using the SGLT2 in that patient to flatten the decline in the eGFR. Now, whether there'll be a background benefit to liver, I don't know. I don't want to kid myself, but at least because everything's happening in the same patient. So we're treating the patient, not just the disease. So I think these are sort of important caveats as we evaluate these patients.
I think that also reflects what we have, that to measure NT-proBNP in all our patients is what they are telling us that we should do. And last, before we leave, what is, Dr. Sanyal, what is your take on FETUIN A and other such biomarkers?
You know, they really have not been very well developed. In terms of what we consider biomarker science, they are very poorly developed, in fact. But there are a number of biomarker panels. So when we think about use of biomarkers, we have to ask ourselves whether we are using the biomarker as to identify the risk of development of fatty liver disease, and there are polygenic scores being developed for that, or whether we are for diagnosis or for risk stratification, which is, you know, you get a biomarker and you follow the patients over time, and then you look at the prognosis and be able to show. And in biomarker development, you also have to show whether the thing can be measured in a consistent manner. So if you draw your blood sample and put it in the machine same tube 5 times, would you get the same result? How much variability? A lot of those kind of, boring but critically important details are missing with a lot of those biomarkers. But there are some that are coming forward. There's one called, I would keep an eye out for the NIS4 and a NIS2 panel, which is based on microRNA 34, YKL40, alpha-2 macroglobulin, and A1C, which is a combined biomarker panel and gives you a score. There's something called the ADAPT score for fibrosis, which is coming. So there are a few which are actually further along in development.
So thank you very much. That was a really wonderful session. I thank Professor Sanyal and all the panelists, Dr. Anish, Dr. Pathak, and Dr. Dakshata, for having taken us through all the doubts that we have. And I'm handing it over to Dr. Vinob again.
Thank you, ma'am.
Dr. Vinob, you are muted. Dr. Vinob.
Sorry. So thank you, Dr. Malam, as well as all the panel members for such an enlightening session. Next, let's move on to the third session. I'd like to briefly welcome Dr. Vijay Vishwanathan for moderating this session. So Dr. Vijay Vishwanathan is the head and chief diabetologist at MV Hospital for Diabetes, as well as Professor M. Vishwanathan Diabetes Research Center, Royapuram, Chennai. Dr. Vijay is the president of the Food International based in Belgium, which consists of experts in diabetic food. He's the National Vice President of Research Society for Study of Diabetes in India from 2019 to 2022. He's the recipient of first Vivian Francesca Award from the American Diabetic Association for research paper on diabetes and TB in 2013. He has published over 20 original research papers in various topics like diabetic food, diabetic nephropathy. He's the honorary faculty in the Department of Podiatric Medicine in Royal College of Physicians and Surgeons of Glasgow. So I'd now like to welcome Dr. Vijay Vishwanathan. Over to you, sir.
Thank you, Dr. Vinob. I think we are running about 20 minutes behind schedule.
Yeah, yes,
but
sir.
we'll finish by 8:30. So we have a very interesting session, and that's on time and range. You can switch off the slide screen for a minute. Yeah, so we have a very interesting session on TIR, time and range. We've heard many times about TIR, but we're going to hear today from Professor Hirsch about TIR, and which is whether it is going to be the standard of care in glucose management. Now you can put on the slide of Dr. Hirsch. Dr. Hirsch is currently the professor and diabetes treatment and teaching chair at the University of Washington School of Medicine in Seattle. And from both the research and teaching point of view, Dr. Hirsch's career has focused on studying the best strategies for the use of insulin therapy in both type 1 and type 2 diabetes. And more recently, he has become more interested in glycemic data management and his relationship to more traditional diabetes biomarkers. He will speak for 30 minutes on this topic. Is time and range the gold standard? After which we have a panel consisting of Dr. Sandeep Suri, Dr. Manoj Chawla, and Dr. Vinayak. So, Dr. Hirsch, welcome to this session, and I'd like to thank INTAS for this invitation. Thank you. Go on.
Great. Well, I want to thank everybody. First of all, can you hear me okay?
Yeah, perfect.
Great, great. Okay. Let me first share my screen and thank everybody for the invitation. It is early in the morning here in Seattle, Washington. I'm actually right outside of Seattle in a suburb called Bellevue. And I very much appreciate the invitation and tell you where we are and also where we may and may not be going with this whole topic of time and range. The title of the talk given to me, which I did not change, is Time and Range, the Gold Standard in Glucose Management, A1C versus Time and Range Nuances and Pitfalls. These are my research and consulting dualities. And let's get started. Is the title assigned to me the right question? That is time and range the gold standard in glucose management? Well, let's think about this for a moment. If we think about continuous glucose monitoring, which let me just preface my comments by saying that continuous glucose monitoring, or CGM, is just exploding in the United States. I was last in India, I guess it was probably early in 2019. I was also there in 2016, and it was just sort of getting started. It was just professional CGM, and maybe in the discussion we can talk about where things are now. But I can tell you, in our clinic at the University of Washington Diabetes Institute, over 90 to 95% of our type 1s use CGM. And in the type 2 insulin requiring patients, which in our clinic is most, 80% of our type 2s in our clinic, because of the nature of our clinic, it's over 50, maybe 60% use continuous glucose monitoring. And we can talk more about that if there are questions. But we talk about time and range as 70 to 180. And I would argue if you just look at that by itself, it's an incomplete number, because one needs to understand an individual's time below range in conjunction. And we're really talking about people on insulin, maybe a few on sulfonylureas. We don't talk much about time above range. It's the difference, but I'm really interested in time in range and hypoglycemia, time below range, which is below 70. So let's look at these three examples. In all three of these patients, the time in range is 80%, but these patients are very different. Patient 1 has a time in range of 80, but a time below range of 20%, less than 70. In patient 2, the time below range is 4%, and every 1% is approximately 15 minutes. So this patient here with 4% time below range is an hour a day, and yet that is the International Consensus Conference target of keeping time below range less than 4%. Now, to be fair, that is a very type 1 centric target, but nevertheless, this patient is just sort of barely making the hypoglycemia target. But yet we have this patient, patient 3, time below range is 0%, with all three of them at 80%. And so time and range is not enough. You really do need to know time below range. And by the same token, I would suggest it's the same with A1C. A1C really gives you a very incomplete number. So understanding time and range, most would agree that a time and range of 80 is good. In fact, the consensus says we want most people above 70. Most would also agree a time and range of 80, but with 20% time below range is not good. I don't think anybody would disagree with that. So as opposed to A1C, one can't speak to an in-target time and range without knowing the time below range. Time and range by itself is not enough. In fact, time and range and A1C by itself are not enough. And let me explain. Time and range is, yes, dependent on time above range and time below range, whereas we know there are many limitations of A1C, many limitations. Differences in red blood cell survival being maybe the most important one. And by the way, as I will show you, A1C does not always predict severe hypoglycemia. It is therefore not surprising that time and range is far from perfectly correlated with A1C. And we've learned this quite a bit over the last 5 years. And the reason, of course, is continuous glucose monitoring. This is just one of many, many studies where you can see A1C on the y-axis, time and range on the x-axis. We have 545 people with type 1 diabetes. And what you can see is that in general, and all of the studies show this, yes, a time and range of 70% approximately correlates to a hemoglobin A1C of 7%, but look at all of the scatter. Remember the scatter, because every study we look at, we are going to see scatter. In fact, you can see time in ranges here in the 90 and 100%. Yes, you have low A1Cs, but you can also see time in ranges in this particular graph in the 80% range with A1Cs in the 7.5%. And this study does not have as much scatter as most. So like time in range, A1C by itself does not predict severe hypoglycemia. These are data from the T1D exchange, the University of Washington. We were the third largest center on the adult side of the T1D exchange. And it needs to be pointed out that these studies were done really before the CGM era. And this was over 7,000 patients, adult patients with type 1 diabetes for a year. And I want you to note that there really is very little difference. Maybe you can see a little bit of a decrease of severe hypoglycemia with an A1C between 7 and 7.5. But as the A1C goes up, even above 10%, we don't really see any difference compared to A1Cs very low, less than 6.5%. And this is really important because typically I will see our residents and our fellows here at the University of Washington say, you know, we need to raise the A1C to reduce the risk of severe hypoglycemia. And at least in the pre-CGM era, that was not accurate. What about kids? These are over 13,000 kids and young adults. And if anything, we see more severe hypoglycemia with the highest A1Cs. And the question is, why is this? Why would you see more severe hypoglycemia requiring the assistance of somebody else with these high A1Cs? Well, the answer, I believe, and I can't prove this, is that when these people see these very high blood sugars, when they do their finger sticks and they see these 300 and 400 blood sugars, they give insulin, but these are patients who are often not checking their blood sugars frequently. And they see it, they give a big dose of insulin, and down they come. And this is what the result of that is. So what does every provider need to know about A1C here in 2022? Well, we know, and I've been really interested in this for many years, there are many things that alter A1C. And this is not a complete list. I will tell you, when we look at all of these things, we can't even, in many patients, understand an individual's A1C discordance. That is, why does this person read higher than the population, and why does this patient read lower? But nevertheless, this is the incomplete list. And so I've stopped trying to figure it out in most people where I have discordance between A1C and blood glucose, whether it's fingerstick or CGM, because more often than not, I can't understand it. I mean, I know if I have a transplant patient or an end-stage renal disease patient with anemia on erythropoietin, and they've had a transplant and they're on dapsone. I mean, in those kinds of patients, I've seen A1Cs in the high 3s and low 4s. But the point is, this is really a mess. And I don't think we really appreciated the mess until we got into the world of CGM. And here in the US, we have 4 different continuous glucose monitoring devices. More are on the way. And one of the interesting things about the COVID pandemic is CGM just exploded then. And one of the reasons was the direct-to-consumer advertising. And patients would go into their primary care physicians and say, I want the CGM, whether it's Dexcom or Libre, which are the 2 that are most commonly used. So what every provider, patient, researcher, and payer needs to understand in 2022 is this concept of glucose management indicator, or GMI. We use the term GMI as opposed to estimated A1C because the US FDA mandated that. They did not want us to use estimated A1C because they thought that would confuse people more. But all this is, it's an average of the CGM converted by an equation to hemoglobin A1C. So it's a metric calculated by CGM-based formula from a population of mean glucose data. And patients can see this whenever they download their data on their phones, on their computers, and certainly in almost every download I can think of except one, the GMI is calculated for us. And so it's very easy to see if there is a discordance between the GMI and the hemoglobin A1C. Why is GMI so important? Well, this was a study that we published last year with 641 patients, all on the Dexcom sensor. We wanted to keep the sensors the same, and we can get into this into the discussion, but the sensors are not all the same. So the sensors were the same, the A1Cs were the same, 641 patients, and I want you to notice the scatter when we look at the CGM mean glucose and we look at the A1C. I mean, here is a patient, for example, with a CGM mean glucose of around 100, but an A1C of about 11.5. And then right above the legend, we have somebody with an average of over 275 with an A1C close to 6. And so this is like maybe the most important slide I'm going to show you when thinking about A1C. And the reason for this is multifactorial. When we generally do studies, and I do a lot of clinical trials, I'm not allowed to have people come in with anemia, with chronic kidney disease, with liver disease, which you just heard about, because we know all of those things will impact the A1C. Well, this is just my clinic. This is just the University of Washington clinic, and this is everybody. This is all comers. And what we showed was that only 11% of people did the GMI, or estimated A1C, exactly match our laboratory A1C, which was an HPLC A1C. Half of our patients, the A1C that from the lab was over 0.5% off. So if the GMI was 7%, the laboratory A1C was either greater than 7.5 or less than 6.5 in half of our patients. Now, we had almost no African Americans. We're in Seattle. This is type 1 diabetes. We don't see a lot of type 1 diabetes we don't see a lot of African Americans in Seattle. And the reason why I bring that up is that we know that on average, for any given glucose, African Americans run 0.4 to 0.5% higher. And so this is a white population. Half of them, the A1C, half of patients, the A1C is 0.5% off from the estimated A1C. And even more surprising, in 22% of our patients, the GMI was more than 1% off. So what that means is that if the GMI, or estimated A1C, was 7%, the laboratory A1C was more than 8% or less than 6% in 22% of our patients. And not surprisingly, we did have a lot of CKD patients in our population. There was increased discordance with the eGFR less than 60. And that's been well described over the years. So I think it's safe to say that neither time and range by itself nor A1C in people with type 1 diabetes predicts severe hypoglycemia. So is there a better way to assess glycemic control? This was a paper that came out earlier this year, very controversial. I was an author on this paper, and it's a new metric called the glycemic risk index. The whole point was, can we do better than time and range and A1C? And the GRI is a composite metric using percent hyper and hypoglycemia to assess glycemic control. You want a lower number. The lower the GRI, the better the quality of the glycemic control. We can't really talk about quality when just looking at A1C. And looking at time in range without time below range, time in range by itself, it's hard to look at quality. And so this is what it looks like. This is what the grid looks like for GRI. You have a hyperglycemia component on the Y, a hypoglycemia component on the X. And notice there is this complex formula that looks at very low, low, very high, high components, and also a hyperglycemia component to do a calculation to calculate one's GRI. Very low gets a greater weight than a low, a greater weight than a very high, and a greater weight than a high. So this is weighted. And so you're going to get a worse score or a higher score if you have a lot of hypoglycemia. So this was the paper. It came out earlier this year. What is the basis? How did this formula get made? Well, we looked at 14-day tracings from 225 adults. Now that's important. Adults and non-pregnant adults with diabetes, and 330 clinicians experienced with CGM analysis interpreted and ranked them from best to worst in quality of glycemia. That's what we did. We looked at the quality of the glycemia. So in trying to understand this, my first thought is we can't individualize time and range. Is it time to progress to consider for each patient a target GRI, which of course includes time below range, hypoglycemia? So let's look at a couple of cases on this. This is a 24-year-old woman, type 1, not considering pregnancy for another 5 years. She's on twice daily glargine. She's on insulin lispro. She wears a CGM. Her time in range is 58%. Her time below range between 54 and 70 is 10%. Her severe hypoglycemia, less than 54, is 4%. You can see her time in ranges. Her GMI looks good. Her A1C is concordant. She has a GMI and A1C only 0.2 off. She's in the low 6s. If you just look at her A1C, you would say she's doing well, but look at all of her hypoglycemia. And because of that, she has a high GRI. Well, what does that look like? She has this good A1C, time in range of 50%. 20 years ago, I think most of us would congratulate her for her success, but do we congratulate her now? So we have these various stages. She is in zone D. It goes A, B, C, D, E. She's in zone D, which is 61 to 80 because her GRI is 61. And we would say that the quality of her diabetes is not very good. Now, let's take this to the next patient. This is a 78-year-old man using an open loop pump with continuous glucose monitoring. He has prostate cancer, coronary disease, EF of 45%, CKD. He has all these comorbidities. His EGFR is 31. His time in range is 52. But look at him compared to the previous patient. Time below range, 54 to 70 is 0. Time below range less than 54 is 0. This gentleman has absolutely no hypoglycemia. A1C is 7.5. But look at this. He has a discordance with his GMI, which is what we would expect with an EGFR of 31. We know the A1Cs are going to be discordant low. But if you just look at his A1C, you would say, well, given he's 78, he's doing okay. If you just look at his GMI, you would say, well, maybe we should be a little bit more aggressive, maybe not. That's a discussion point. But look at his GRI. His GRI is quite high. And in fact, compared to our last patient, his GRI is in zone D, way here at the top. And you would say the quality of his glucose control is poor. But I would say, now, wait a minute. He's having no hypoglycemia with all of these comorbidities. So he's 78 years old, all these comorbidities, probably life expectancy is not long. He's in this way we look at this GRI, he's in a poor GRI zone of zone D. And the question is, this is a gentleman, we really want to avoid hypoglycemia. This doesn't really work if you think about it, at least for this type of patient. Let's go to the next patient, our last patient, 81, MDI, degludec and aspart. She also has all these comorbidities. Now look at her. She has a time in range of 52, a time below range of 7, 54 to 70, a time less than 54 of 3. Her GMI is 6.6. Her A1C is 7.1. And again, that is not unusual to have this 0.5% discordance. And her GRI is in zone C. So again, it's not great, but it's better than the last patient. And so this lady who has a better GRI than the last patient, she's in zone C, but look at all of her hypoglycemia. And so I'm scratching my head, and I've been thinking about this a long time, and I'm not sure that this GRI really works, because we have this consensus guideline where we want people with comorbidities to have time below ranges less than 1%. And what that really means is that for these people with comorbidities, we can have a GRI less than 1%, and they can still be like our second patient, having a zone D GRI, which is considered poor glucose control. And I'm not sure for these kinds of elderly patients that makes a lot of sense to me. So my conclusion is yeah, this is an important new metric based on adult, otherwise non-frail patients. My hope is actually it will become part of the standard CGM download. I'm fascinated with the data, but I have a lot of concerns. It's not relevant for elderly frail patients with limited life expectancy. It's not relative for pediatrics. It's based on a survey of adult patients, and it's obviously not relevant for pregnancy. So again, is time in range the gold standard in glucose management? And I would say that hopefully you are convinced that time in range by itself needs more context, specifically time below range, and these targets need to be individualized. A1C by itself also has limitations into what it represents with mean glucose and its risk for hypoglycemia, especially in type 1 diabetes, where we have some very provocative data. GRI, I think, is an important new metric, but like others, it obviously has limitations. There's no perfect metric for looking at glycemia. What we need now is understanding by both clinicians and patients the limitations of A1C. I don't think that this information is well appreciated. Consensus for both time in range and time below range, and for that matter, GRI for different populations. It's my opinion that if you look at A1C, time in range, and GRI, the best is the combination of time in range and time below range. I think for the average clinician not doing the research, that is the key information you want to know for patients taking insulin. We have to think about different consensuses for adults for targets, pediatrics, and obviously pregnancy. Elderly and frail, everything's going to be different for all of these. But to the original question, is time in range the gold standard in glucose management? I would say it's complicated. I think time in range with time below range is right now the best we have, but I'm always interested in seeing more data and debating this topic. That's the fun part of all of this. And I hope you found this interesting. Thank you very much. This is literally we don't have snow right now this time of year, but this is about a 60-second drive up from where I'm coming to you right now. This is the, you can see, this is the Seattle Space Needle, very iconic. This is downtown Seattle, and these are the Olympic Mountains in the background. Thank you all again.
Thank you, Dr. Hirsch. I think your topic was brilliant, and you introduced us to some new concepts apart from TIR like GMI and GRI. So it was a big learning experience for all of us here. So we now open to a panel discussion, and we have Dr. Sandeep Suri, who is a senior diabetologist at the Advanced Diabetes and Critical Care Holy Help Hospital, Hisar. And you can read the rest of his CV. He's a senior diabetologist. Next, we have, next slide. We have Dr. Manoj Chawla, who is currently director and consultant diabetologist at the Lina diabetes care in Mumbai Diabetes Research Center in Andheri, and he is a well-known figure in the field of diabetology. Next slide. And we also have Dr. Vinayak, who's currently a consultant adult and pediatric endocrinology at the Supreme Clinic, Jupiter Hospital and DY Patil Medical College in Pune. So thank you very much, and you can stop the slide share. Yeah, so my first question is to Dr. Sandeep Suri. You heard from Dr. Hirsch that the HbA1c has got a lot of limitations. So with these limitations, what Dr. Hirsch mentioned, do you think that CGM will replace HbA1c one day in India? And do you think it's complementary to A1C, or will it replace A1C? So Dr. Suri.
Yeah. Good evening, sir. Good evening. I'm audible?
Yeah, very much.
Okay, sir. So first, I must thank Professor Al for the great prospective talk, and it's making CGMS more applicable and more understandable to us. So the concept of CGMS begins with the blood sugars. Blood sugars dynamic pattern, dynamic process. It is not a static process. It has got its pattern, it has got its trends, it has got its directions, and also ranges. So never a static snapshot value is going to give you the exact picture. And the precise information will never be given by a snapshot value. So A1C till today is an indicator of chronic glycemia for the past 90 to 120 days, best correlated, best validated in various trials, right from DCCT until date. We have got all trials indicating that A1C is directly correlated with various complications. We call it a gold standard for management of diabetes, standard of management of diabetes. But the concept is beyond A1C now. We are talking about beyond A1C. So why it is so? Because it is missing two things. Number one, the two things which are dependent of A1C value is dependent upon RBC lifespan and also rate of glycation. And so many things have been enumerated by Professor Earl, and he says that the slide is incomplete. And the second thing is it misses hypoglycemia, and also it misses acute hyperglycemia. What CGMS tells you, it gives you the dynamic values. It gives you time in range, it gives you time below range and time above range. It also gives you 24-hour glucose profile. We call it AGP report, and also glucose management indicator also. And it is a colored bar system or colored views which you can get, and it makes patients much more aware. You can involve your patient in the whole process of management of diabetes. So the best patient-centric individualized precision medicine right perspective is by CGMS. So it is more actionable, where you get the HbA1c report. What you have to do, it is similar percentage. Suppose I give you percentage of 9%. What to do now? So the thing is that you have to alter the therapy, definitely, but where to alter the therapy? Whether it is the lifestyle which is going to help you, diet, exercise, OAD you are going to alter, looking at hypos and hyperglycemia, which insulin you are going to use, what pattern of insulin you are going to take in this patient. So the best way of using highly precise way in treatment of diabetes and watching the results in front of you within next 5 days or 14 days, it is CGMS. But let me say, sir, we are very democratic. We want to have both values with us. As a diabetologist and endocrinologist, we are very much liberal. We all take everything along with us. So A1C plus SMBG, most of the time, it is structured SMBG. And if there is discordant results, patient is high risk for hypoglycemia, CGMS is being used. And we are basically using both A1C and CGMS data.
Thank you, Dr. Suri. I think Dr. Manoj is in 2 meetings simultaneously.
Yes. I'm here with you, sir. Right.
Yes.
Thank you.
So, Dr. Hirsch, can I ask the same question to you? Do you think that CGM will one day or the other replace A1C?
What was really, I don't think it will ever completely replace it, but it's making us realize more and more we don't need it. first of all, I appreciate that not everybody in any country in the world, including the US, not everybody has access to CGM. But I think there is a more compelling point. We've been looking at A1C for years. It came in the 1980s. We started using it because it was a biomarker for hyperglycemia. And what happened over the years is that, yes, we then got the DCCT and the UK PDS, and now we use this. The payers use it, the regulatory agencies use it because it is just entrenched in our society. But having said that, the A1C is a biomarker of glucose. It doesn't always work for every patient. And why do we need the biomarker when we can now actually measure the glucose? It's the glucose that's the problem. It's not the A1C. Now, as it turns out, in a population, if you are doing a clinical trial or you're looking at your practice, A1C is a wonderful biomarker because all these changes that occur wash out in a population, especially if you're doing a clinical trial. But when you're looking at one individual patient in your clinic on that day, and you have the A1C, you don't know what that means in terms of average glucose, let alone if that patient is taking insulin, how much hypoglycemia they are having. There have been now numerous trials, both in type 1 and type 2, showing that the time and ranges do correlate to microvascular complications. I didn't have time to show you those data, but the big problem we're having in the United States right now is, as of now, our FDA, for regulatory reasons, are not yet allowing time and range for new drug applications. I think that's going to change in time. Do I think that time and range will replace A1C? No, I don't think that will ever happen. During the pandemic, when people were locked down, but we were doing everything virtually and all of their CGM data was going to the cloud, I was just using GMI. And if I have the GMI, I don't even really need the A1C. And in my practice, where I am in Seattle, and just so you know, my clinic is literally across the street from Amazon. The Amazon World Headquarters is across the street. So we see all of these Amazonians, is what we call them, and we do the A1Cs because the insurances ask us to. But if I have the GMI and the CGM time and range data, that's all I need.
And thank you, Dr. Harsh. Manoj, you heard that CGM is a very useful entity. Now,
Right.
our practice among your people, diabetic patients, what is the acceptability of CGM, especially being in Mumbai? And if there are some challenges, what are they? Manoj Chawla.
Thank you for that. Let me start with thanking Dr. Al Hirsch for that wonderful presentation, especially the introduction to the glycemic risk indicator as one of the other matrices that we're going to be looking at. Having said that, so yes, I do continue to use CGM very, very frequently in my practice. Have been working in that field for a while. Did author the CGM Indian guidelines in 2019 as well, sir. Now, in terms of the acceptance, it's gradually improved. So if I go back and draw parallels to what happened with the HbA1c investigation itself, a decade and a half back or 2 decades back, we had to speak to our patients to introduce the concept of HbA1c, let them know why we want to see it, what does HbA1c mean, why just that fasting and postprandial or the occasional SMBG was not good enough. And then the patients accepted that. And then every time that they would come in, they would get their HbA1c or ask for a point of care HbA1c as things moved on. Similarly, for CGM, it's been a concept that we've been trying to introduce and talk to the patients, letting them know why there is a need to move beyond SMBG and HbA1c and why we need to see the whole movement and the profile, and then talk to them about CGM. And many of them have started accepting that. Yes, in a self-pay market, the cost will always be the largest barrier. And I think that's the only barrier that I see. Pretty clear in my mind that CGM is a tool not to be restricted only for type 1 patients or type 2 on insulin, but a tool for every individual with diabetes, including those with pre-diabetes who want to see the impact of how their lifestyle is impacting every aspect of their movement. As I said, sir, the only limitation is where one cannot afford. And then there are some specific challenges in patients where probably the occasional rash coming in, or just the data not picking up with a particular CGM technology, those are very, very limited aspects. One other thing is still the concern for accuracy in the lower zone. So the over hypoglycemic movement that we see in a lot of patients who remain on the lower side still does continue to be a concern, especially since when we talk about FGM, we talk about the Abbott series, which is predominantly used in India. We still are stuck on to sensor 1. Fortunately, US and many other zones have moved to the 3rd generation sensor or Libre 3. We still in the 1st generation sensor do have those little concerns of accuracy, especially in the hypoglycemic zone. But beyond that, I think it's time that we all started speaking to our patients. Some of them may not accept it this time, but as time passes, the fact that you've spoken to them, introduced the concept, they do. And in our practice, we now see patients coming back and asking for the second time to do a CGM. And the other aspect has also been, especially in patients on insulin, the movement from the professional CGM to the freestyle, the real-time CGM. And that, I must say, is actually the CGM which helps patient make changes. The professional one is what we were used to, and we were hung on to that for the longest time, also because that's more economical here. But that has its own limitations, great for pattern seeing, especially in type 2. But for those on insulin and type 1s, it has to be the real-time freestyle series, which is making a huge change in their metabolic parameters.
Thank you, Manoj. It's quite encouraging to know that the CGM technology is picking up fast in India. So
may I make a comment? May I make one very quick, actually 2 very quick comments to those comments, which I agree with. Ed Damiano, a colleague of mine who does the Beta Bionics artificial pancreas, he looked at the original Freestyle Libre when he was doing some of his original studies. And to the specific point of hypoglycemia, with that original Libre, the MARD, which is how we look at accuracy, we want that MARD to be in single digits. But in the hypoglycemic levels less than 70, he showed the MARD was 36%, 36 with that original Libre. It's not quite as bad with the Libre 2 and 3, but I think that's important. The other thing I want to just point out is that it is my hope this is going to become cheaper and with better technology. What I am most interested in, full disclosure, I'm a consultant for the company, but looking at non-invasive glucose monitoring. We've been talking about it for 30 years, but I believe this is going to happen in the very near future. There are several companies. The one I work happens to be in Israel that works with a radio frequency that measures the blood glucose, not the interstitial fluid glucose. I actually presented the data at ATTD, and we are looking at very, very accurate levels in the hypoglycemic levels, because every glucose level has its own signature, the way it's reflected from the blood glucose capillary in the dermis. And so I think this is going to get cheaper, and I think it's going to get more accurate over time.
Thank you, Dr. Hirsch, for the
Dr. Vishwanathan, can I ask one question if I'm not interrupting Dr. Hirsch?
Yes,
there's always been some concern, not concern. I mean, there's a question that I've asked often about the TIR guidelines and matrices, which are largely based on real-time CGM. However, in many parts of the world where it's the professional CGM used, people try to draw parallels for the TIR recommendations based on professional CGM. Though the fact is that the entire paper and all the data has been on the basis of real-time CGM. So your comments on that, whether it is still valid, the same aspects when you use professional CGM.
Dr. Hirsch.
We did not, so with those consensus, we did not consider professional CGM. I think it's it's a different animal, both in the type 1 and in the type 2 populations. I should also point out one of my huge interests is atypical forms of diabetes, but nevertheless, you can't extrapolate that. And one of the reasons is that whether you're using a Dexcom for 10 days or an Abbott for 14 days, we know that not everybody behaves the same with their lifestyle for that relatively short period of time. And making those assumptions is just inappropriate. And so those consensus guidelines are just for real time.
Thank you, Dr. Harsh. So, Dr. Vinayak, you are an adult and pediatric endocrinologist. So, do you agree that CGM is a very useful tool, especially for your pediatric patients? And do you think that considering the cost, it's a drawback in Indian children? And one more last question, you think that CGM is useful to differentiate Somogyi phenomenon from Dawn phenomenon, which happens in children when they're taking basal bolus insulin regimen? Yeah, Vinayak.
Yes, sir. Thank you, sir. Thank you, Professor Alash, for introducing this new concept of glycemic risk index. So coming to your question, sir. So among pediatric patient, type 1 diabetic patient, although sir has mentioned in his lecture that almost more than 90% patient in their type 1, they are using CGM, but it's not there in our case. Means main issue is the affordability. One sensor is almost 5,000 rupees cost. So many times they do not continue unless there are certain events or recurrent risk of hypoglycemia. But yes, they do SMBG in a there as a routine practice, but CGM is not where I can't find in most of the patient. They are continuing in their regular practice. Means ideally it has to be there by 24/7 for almost a year. So that is the main constraint is because of the cost. But those who are using, they are really getting benefited. They are getting their time in range. It's a good motivator for them. But what I understood I'm not very senior like others, but in my clinical experience, only the patient education, the more I speak with them and give them the knowledge or benefit about the CGM and how it will control their glycemic variation, and it will reduce the long-term complications. So it's going to definitely it will increase the usage in future. Only the counseling is very much important. But yes, cost is the main constraint for the patient, those who are with the poor background. And regarding this, the other question is the Somogyi phenomena. So that is really it get really reflected with the CGM data. It is not really by SMBG. It's not very much useful to differentiate, but by doing the CGM in these patients of type 1 diabetes, we do get more data on early morning hypos or hyperglycemia.
Thank you, Dr. Vinayak. So, Dr. Harsh, 5,000 rupees is about $862. So that's the cost of the sensor. He said 5,000 rupees, so it's about $62. So it's quite expensive in India to get a sensor. Dr. Sandeep Suri, using CGM data, you use it as a good tool to change the medication, whether it is insulin or oral drugs. Would you find it as a good tool to change the medication dosage and so on?
Yes.
And also same with Manoj also.
Yeah. So actually, this is the data which we can use for altering the therapy, not the OADs or insulin. You can improve your lifestyle. You can do more exercise. You can walk more. You can have more footsteps also. Physical activity can also be improved. Your snacking, which has got another impact on glycemia, that can also be taken care. And then the therapy alteration is very important, specifically when you want to have PPG spikes to be taken care by peglutides or AGIs, usage of AGIs, altering the diet, carbohydrate intake, increase fiber and increase protein intake. And then you have basically compliance to your lifestyle modification, compliance to medication, compliance to insulin also improves. When you see those valleys and mountains, they are now gone. You have become more flat and narrow in range. That makes a sense that you are controlling it. that the burnt out concept of diabetes, that it is very frustrating that things are not getting under control. You can bring it back. You can bring it back and patient will be much more involved. Looking at nocturnal hypoglycemia, as Dr. Vinayak already told you, that it is early morning hypers or hypoglycemia, smog eye, and dawn phenomena can be very easily taken care. Altering basal insulin, whether you are changing the type of insulin, doses of insulin, timing of insulin, everything can be changed. And the patient gets much more involved, and the things become much more in control of the patient. So this is the beauty of CGMS that makes us more precisely acting at particular time, that which type of therapy will work for this patient.
Very true. So supposing you have a person with CKD stage 4 with the EGFR of 30, we are really scared of hypoglycemia. So my question to Manoj, would you recommend the CGM, particularly in people who have severe comorbidities like an ejection fraction of 30%? We don't want hypoglycemia, or CKD stage 4. Yeah, Manoj.
Absolutely, sir. I think any individual who is having fluctuating blood sugars, where hypoglycemia would be more catastrophic, this aspect of monitoring is going to be far useful. Having said that, there is a caveat to the same that I would like to add. And I'll give you an example for a patient of mine with CKD who was on some oral drugs, a combination of glenides and etc., who had an episode of severe hypoglycemia at home. Now it's been 1 week to the same. They've been monitoring, doing SMBG at home, and patient continues to remain now. His sugars remain in the zone of 70 to 80 at home. The family was concerned initially, required counseling that now this patient is off all drugs. So if this patient with CKD, if you're seeing sugars in the 70, 75 range, do not panic. He's not going to go into further hypoglycemia because there are no drugs. The question the family asked is, shall we put this patient onto CGM and monitor that? And my answer was no. Because this is already an individual whose sugars are in the 70 to 75 range. And if I'm going to use the current technology, I'm very, very certain that you're going to see a lot of red zones in the 60s to 70s. And that's going to create panic for an individual who's currently not on any drugs. So we shouldn't be worried about hypoglycemia. So that's a specific case where I'm talking about. Having said that, a lot many others who are on drugs, who want to monitor, even the ones on dialysis, I think absolutely wonderful tool to see how the movement is and make it far more safer, especially the real-time ones. The direction that they're able to see prevents any kind of severe hypoglycemia, allows them to take an action in time when they see the direction and where the sugars are headed. So I think that's, having said that, this is the time that a lot of us are moving for our patients from professional CGM to real-time CGM. It does require a little training for the patients as well. My other observation has been the patients overreacting to the direction. So I've seen a lot of patients who are monitoring the type 1s and they start seeing in the night if the sugar is 110, say 2.5, 3 hours after meal, and it's going slightly down. They're afraid that they'll go into hypoglycemia in the middle of the night and they start snacking unnecessarily to land up with a 170, 180 in the morning. So we also need to tell them not to overreact to that arrow because the effect of your drug is over and you not necessarily are going to go. So a lot of learning for us and the patients as we continue to use this technology.
Yeah, very good point, Manoj. In the interest of time, we should close. Dr. Hirsch, any final comments from you from Seattle?
I appreciate it. No, I appreciate the invitation to talk. There's a lot more I didn't get to, and because we are learning so much about this interaction of CGM and A1C, and I just want to thank you again for the invitation.
Yeah, and we look forward to seeing you in India, giving a talk on GRI and GMI. So thank you, everybody. And thank you, Dr. Hirsch, Dr. Sandeep Suri, Dr. Manoj Chawla, and Dr. Vinayak for joining. And we are about 40 minutes behind schedule. So I close here and hand over to Vinod.
Thank you. Thank you for the wonderful moderation, Dr. Vishwanathan. Thank you.
Thank you, Dr. Vijay, sir. On behalf of Intas Pharmaceutical, I'd like to thank Dr. Vijay Vishwanathan, Dr. S.K. Sharma, and Dr. Bala Dharmalingam for moderating the sessions. And of course, I would like to thank our international faculty, Professor Hurst, Professor Ildiko Lingve, and Professor Arun J. Sanyal for joining us here today. I'd like to thank all our expert panel members for taking out time from their busy schedule and making this event a highly interactive and successful. Last but not the least, I would like to thank all the audiences who have joined us this evening. Thank you, one and all. Good night.
Thank you very much. Bye.
Thank you.